Hello friends, let us come to the session of OBS and Gynae. I am Dr. Harmeet Goel, your OBS and Gynae faculty. Today I am here to discuss the last 5 years FMG exam previous year's questions for your preparation for upcoming exam in 2024. So I have collected almost all the questions which have been asked in last 5 years of FMG exam, but my main focus is on last 3 years exam. Suppose a question is been asked in the different FMG exams 3 to 4 times, so I have added it only once, okay, otherwise the discussion will become too lengthy, and this discussion will be really helpful for your upcoming exam of FMG in 2024, okay. So stay connected and welcome to this session. I have done my MBBS from Lady Hardinge Medical College, post-graduation in OBS and Gynae from VMMC Safdarjung Hospital, Delhi, and I am teaching the FMG batch for last 2 decades. Presently, I am working as a consultant gynae in Preventive Oncology Department of Rajiv Gandhi Cancer Institute and Research Center, Rohini. Now, I am taking up the questions which were asked in 2023 exam, June exam. Now, first question is, welcome you all. So, my first question is, what hormones are secreted by Leydig cells and Sertoli cells respectively? So, the options are DHA and testosterone, testosterone and inhibin, testosterone and DHA, inhibin and testosterone. So, I can read your chat in another system. So, you can keep on writing your answers. I can read Dr. Rudra, Dr. Jugal, Dr. Patel, Dr. Dinesh. So, good evening everyone. Namaste. So, I can read Dr. Muskan, Dr. Rudra, Dr. Jugal, Dr. Patel, Dr. Dinesh, Dr. Sheikh, Dr. Shivam, all of your answers. And the correct answer is, friends, Leydig cells secretes testosterone and Sertoli cells secrete inhibin. So, this is the correct answer. So, testosterone is secreted by Leydig cells, and which receptor is present on the Leydig cells is LH receptor, and on the Sertoli cells FSH, that is follicular stimulating hormone secreted by the anterior pituitary. Welcome you all. Dr. Dipali, Dr. Ravi, Dr. Aftab, Dr. Sandeep, Dr. Shivam, welcome you all. And this is a long number of questions, plenty of questions, because twice a year exam is there, okay. So, in every exam there are around 30 to 35 MCQs of OBS and Gynae, okay. So, it is going to be very crisp and precise discussion, not a very detailed discussion, otherwise I have to leave some of the questions which I don't want, okay. So, this will definitely boost up your confidence level in upcoming exam. What are the other hormones secreted by Sertoli cells? One is inhibin, number 2 is Mullerian inhibiting substance that it secretes in the 7th week of pregnancy, which inhibits the Mullerian duct, because Mullerian duct derivatives are uterus, cervix, fallopian tube and upper vagina, which the nature does not want it to happen in the male. And the third hormone it secretes is androgen binding protein, okay. So, I hope you have got. In one of the exam they have asked inhibin in males. Inhibin in males is secreted by, this is 2018 question, this is 2023 question. So, the answer is inhibin in males is secreted by Sertoli cells. In females it is secreted by granulosa cells. So, this is my question number 1. So, this I have already explained that the Leydig cells secrete testosterone and the Sertoli cells secrete inhibin, Mullerian inhibiting substance and androgen binding protein. Question number 2. A female undergoing IVF was given HCG injection for ovulation trigger, now presents with nausea, vomiting and headache. The ultrasound of the pelvis was done and it shows ascites. Ovary looks like the image given here, and what is your probable diagnosis? So she is a case of infertility where IVF was to be carried out and beta HCG injections are given to trigger the ovulation, and ovulation induction must have been given in the form of Hmge and GnRH analogues. Okay, so beta HCG injection is been given to trigger the ovulation. So which of the following is the most probable diagnosis looking at this ultrasound image? So options are thecal lutein cyst, ovarian hyperstimulation syndrome, polycystic ovarian syndrome or serous cyst adenoma. Now I can read your answers. Welcome you all. Dr. Muskan, Dr. Mithu, Dr. Prakash, Dr. Sandeep, Dr. Medico, Dr. Nikar, Dr. Rahman, Dr. Bhupinder, Dr. Shoaib, Dr. Patel, Dr. Kumar, Dr. Rudra. So all of you are correct. This is no other than ovarian hyperstimulation syndrome. When ovulation induction is been given in the form of Hmg, which is an FSH injection plus GnRH injection, okay, and then beta HCG is added, injection is added to trigger the ovulation. So as a side effect, if there is multiple stimulation of the ovaries takes place, so a condition is reached where it is called as ovarian hyperstimulation syndrome. Many times a student has marked it as polycystic ovaries. Friends, this is not polycystic ovary. This multiple cysts can you see, okay? So this is ovarian hyperstimulation because so many follicles you can see, cyst formation has taken place. So the correct answer is ovarian hyperstimulation syndrome. And which is the drug which most commonly causes ovarian hyperstimulation syndrome? Answer is Hmg injection, human menopausal gonadotropin injection. Next, so my third question is, all of the following regarding non-scalpel vasectomy are correct except. So this has been asked in the Fmge. All this is our previous Fmge exam questions from 2023 back to 2018. Okay. So sexual function following healing is rarely affected. Number 2, hematoma in up to 5% of subjects may occur. Number 3, sterility immediately after vasectomy. Number 4, recanalization is possible. So which of the following is a wrong answer according to you? So can you tell? Yes, I can see your answers. Dr. Rudra, Dr. Sheikh, Dr. Naveen, Dr. Dinesh, Shoaib, Jugal, Shivam, Muskan, Dr. Prakash, I can read Dr. Sandeep. The correct answer is sterility immediately after vasectomy is a wrong answer. Why? Rest all are correct options, okay? These are true and this is false. Why? Because whenever vasectomy is done, a backup method is needed for 3 months because this is testis, this is epididymis, this is vas deferens. Okay, so sperm production occurs in the testis, then for sperm motility and maturation, it enters into the epididymis, from there it enters into the vas deferens. So when you are cutting the vas deferens, that is what is called as vasectomy. Suppose you have cut the vas deferens, okay, this is vas deferens, this is epididymis and this is testis. So when you are cutting the vas deferens, whatever sperms are there in this part of the vas deferens can stay there and leads to pregnancy. So a backup method is required for 3 months and then a semen analysis must be done to check that there are no sperms in the semen. So backup method is needed. So immediate sterility is not achieved after vasectomy. Fine. Now by the way, what is the failure rate of vasectomy? It is 0.15 per 100 women year. 0.15 per 100 women year. Next, question number 4. Which of the following conditions require a serial determination of pregnancy test? How do you detect the pregnancy test? By detecting the beta HCG in the blood or in the serum or in the urine. Okay, so when you talk about the serial determination of this test, this is recommended for a molar pregnancy, viability of pregnancy, gender identification or RH incompatibility. What's your correct answer? Dr. Muskan, sterility, we always say, like for 3 months a backup method is required. Fine. Okay, so what is the answer according to you for this question? Yes, I can read the correct answer. Dr. Vamshi, Krishna, you have written it correctly. Dr. Prakash, Dr. Mithu, you have written it very correctly. It is for a molar pregnancy. We require a serial beta HCG determination for a molar pregnancy, or it is also needed because when you are doing, you have diagnosed the molar pregnancy by an ultrasound which shows a snowstorm appearance. Okay, then you go for suction evacuation method to evacuate this grape-like vesicles. Okay, these grape-like vesicles produce beta HCG, and beta HCG is an important tool for follow-up after you have done the suction evacuation for a molar pregnancy. So serial determination is required. Weekly it is done till negative for 3 weeks. Then monthly it is done till negative for 6 months. During this follow-up time, your patient should not conceive. So which is the best contraceptive during the follow-up time is always the oral contraceptive pills. Fine. Next. Question number 5. Drugs for medical abortion is mifepristone 200 milligram and methotrexate. This is wrong. We don't use methotrexate for abortion. So these two are almost opted out. Now we have to select mifepristone. What is mifepristone? Mifepristone is Ru486. Okay, and mifepristone is anti-progesterone. Okay, and progesterone is the hormone that maintains the pregnancy. So it is anti-progesterone, and misoprostol is given 800 micrograms after 48 hours. This is the correct answer. Okay, we give mifepristone 200 milligram oral and misoprostol 800 microgram by the vaginal route. Up to how many weeks of pregnancy and medical abortion can be done by these drugs? Answer is within 9 weeks of pregnancy. But the best results are obtained if it is used within 7 weeks of pregnancy. Fine. Next. Question number 6. A young girl complains of not attaining menarche, presents with periodic abdominal pain. Okay, periodic abdominal pain means cyclical pain abdomen every month, and she comes to the hospital. On examination, the following presentation is seen, which is given in the image. What is the likely diagnosis of this female? What's your answer? Options are imperforate hymen, number 2 Bartholin cyst, number 3 Gartner's cyst, and number 4 septate uterus. So before I discuss this, let me tell you, Bartholin cyst has nothing to do with primary amenorrhea. She is not attaining menarche. That means it is a case of primary amenorrhea, because they want to give you an image based question. That is why the question statement is very incomplete. In the question they write primary amenorrhea and patient is not attaining menarche, plus there is a bluish membrane which is bulging. That should be the correct format of the question. So Bartholin cyst, Gartner's cyst and septate uterus is never the cause of primary amenorrhea. From this is imperforate hymen, and this condition is called as congenital cryptomenorrhea. Congenital cryptomenorrhea, that means hypothalamus, pituitary, ovary, uterus, whole axis is normal. endometrial lining is been formed, endometrial shedding is been occurring, but there is no visible outlet because of the imperforate hymen. So this menstrual blood will keep on collecting in the cervix, in the vagina, in the uterus. So another name for this is hematocolpos. Now it can be written as congenital cryptomenorrhea, hematocolpos, or imperforate hymen. And what is the treatment? Treatment is cruciate incision and drainage. Treatment is cruciate incision and drainage. Okay, next. Another question, a 16-year-old female visits gynae OPD with cyclical pain abdomen, menarche not attained. On examination, breast is normal, pubic hair are normal. That means ovarian function is normal because ovary releases estrogen, which is responsible for normal breast development. So in this case, the secondary sexual characters of this female are normal. Per rectal examination, uterus is felt. So you have to take the consent while you're doing the per rectal examination. And local examination, bluish membrane bulging. So if you see the image, this should be the exact image and this should be the exact question. So what is your management? You know that this is a problem of imperforate hymen. Is estrogen progesterone therapy going to help? No. Are you going to do gonadectomy? It is not a syndrome. I am not going to do any gonadectomy in this case. Only estrogen? No way. So the correct answer is cruciate incision and drainage. So this is my question number 7. Fine. Okay. Question number 8. A mother brought her daughter to the gynae OPD with not complaining of menarche. Hormonal status shows FSH, LH normal, normal breast development, pubic hair normal, small blind vagina and absent uterus. So when it is absent uterus, you have to differentiate a Mullerian agenesis from androgen insensitivity syndrome. Androgen insensitivity syndrome is called as testicular feminization syndrome, where look-wise it is a female, but actually the genetic sex is a male. Okay, in this case the breast development will be normal, but axillary pubic hair will be absent because of the defect at receptor level. In Mullerian agenesis, breast development will be normal and axillary pubic hair will also be normal, and per rectal examination uterus will be absent and there is blind vagina. So karyotype in Mullerian agenesis will be 46XX and in testicular feminization 46XY. Okay, so here the answer will be Turner syndrome, androgen insensitivity syndrome, or Mullerian agenesis. So Dr. Mithu, Dr. Strange, Dr. Sandeep, Dr. Panchal, Dr. Garima, Dr. Vamshi, Dr. Rudra, Dr. Blue, Dr. Mithu, I can read your correct answers. This is Mullerian agenesis. I hope it is very, very clear to you. Now question number 9. Now 25-year-old female attends the gynae OPD with secondary amenorrhea. Previous history of DNC and FSH levels are 6 international units per liter. Normal FSH level is 5 to 20 international units per liter. So this FSH levels in this question is normal. So whenever a DNC or any curettage is done leading to secondary amenorrhea, this occurs because if you have done a very vigorous curettage, there will be formation of adhesions or synechia, and this condition is called as Asherman syndrome. This plenty of times I have been discussing in my classes. So whenever there is a history which is curettage followed by secondary amenorrhea, and FSH levels are given normal. Students, this was an AIMS PG question, but they have started asking in Fmge exam. So let us read the options. Sheehan syndrome, Asherman syndrome, premature ovarian failure, or is it pregnancy? So all of you, Dr. Rahman, Dr. Harsh, Dr. Panther, Dr. Mithu, every one of you have written it very correctly. This is no other than Asherman syndrome. DNC followed by secondary amenorrhea plus FSH levels normal. It is no other than Asherman syndrome. Now, what will be the gold standard investigation in this case? Gold standard investigation in this case will be a hysteroscopy. Will be a hysteroscopy, because you can do hysteroscopic guided adhesiolysis. That will be the treatment for Asherman syndrome. Question number 10. An intern conducts a delivery. Immediately after delivery, the mother experiences breathlessness, hypotension, tachycardia, collapses, and per vaginum examination is normal, no excessive bleeding. So intern is conducting delivery, and after the delivery the mother collapses and she has breathlessness, hypotension, but there is no excessive bleeding. So it is not PPH, it is not DIC, it is not acute uterine inversion, because in acute uterine inversion the history is like for example, you are forcibly extracting the placenta and placenta did not come out, it is the uterus which has come out. Okay, so such kind of history, or the blood loss which is out of the shock, which is out of proportion of blood loss. This is the way that they frame the sentence for acute inversion of uterus. So when she is collapsing, breathlessness, tachycardia, cyanosis, then it is no other than amniotic fluid embolism. Right? Next, question number 11. Which of the following? So I have already told you, because there are plenty of questions in this session, and aim was to give you a boosting up, because OBS Gynae is very highly scoring subject, and in my 2 decades of teaching I have never found any student telling कि हम OBS Gynae नहीं कर पाए अच्छे से. ठीक है? So it is very highly scoring. Welcome Dr. Rahul, Dr. Ramesh. Welcome you all, Dr. Rahul Soni, Dr. Rahul Bharadwaj, Dr. Harsh Rawat, Dr. Prakash. You all are welcome to this session. Okay. So next. So which of the following is an indication for surgery in ectopic pregnancy in a woman desirous of another pregnancy? This is an important question. Okay, previously they were asking most common site for ectopic pregnancy, earliest to rupture, late to rupture, but now they have asked another question, which is an indication for surgery in ectopic pregnancy, okay, in a woman who is desirous of another pregnancy. So patient wants to continue pregnancy, this is never done, because ectopic pregnancy sooner or later the patient will collapse and it cannot be continued. Ectopic mass more than 4 centimeters, serum beta HCG less than 1000 milli international units, unruptured ectopic pregnancy. Friends, for these 2 indications, I am going to offer her medical treatment. Okay, criteria for medical treatment is size of ectopic less than 3.5 centimeters, cardiac activity absent, okay, and the beta HCG level should be as less as possible, okay, as less as possible beta HCG level, okay, and patient should be hemodynamically stable. Okay, so beta HCG less than 1000 and unruptured ectopic pregnancy, this goes in favor of a medical treatment. So what is an indication for a surgical treatment is ectopic pregnancy mass more than 4 centimeters will be an indication for a surgical management. Surgical management can be done laparoscopically, and we go for a linear salpingostomy. Linear salpingostomy, where we give a nick onto the ectopic pregnancy, we give a nick onto the ectopic pregnancy, take out the ectopic pregnancy and do not stitch it. Let it heal by secondary intention. This can be done by open laparotomy or it can be done by laparoscopy. Fine. Wow, great Dr. Rahul. It's great. Yes, you can definitely get good rank in NEET PG as well. So all my very best, and I'm going to soon, come up with a live session of NEET PG OBS Gynae last 5-year questions as well. Stay connected, Dr. Rahul, and very, very congratulations that you have got a good rank in INI CET. Doesn't matter, you will definitely, your rank will be upgraded in NEET PG. Do well and prepare well. Okay, stay connected. Now next question, question number 12. A pregnant lady with 32 weeks of pregnancy, blood pressure is more than 140/90, pedal edema, dipstick method 2+. So this is 2023 Fmge exam question. What would you like to say? What about this condition? Is it preeclampsia? Is it abruption? Is it postpartum hemorrhage, or it is placenta previa? What's your correct answer? What's your correct answer? Yes, Dr. Ramesh will try to share you the PDF as well. Dr. Vamshi, Dr. Kunal, Dr. Garima, Dr. Sanjay, yes, all of you are correct. This is preeclampsia, blood pressure plus protein urea. Although protein urea has been eliminated from the criteria of severity. If you want to talk about mild preeclampsia and severe preeclampsia, we take the parameter as blood pressure and we take the parameter as end organ damage. Okay. Proteinuria does not signify the severity, but for the diagnosis, like if blood pressure is raised plus proteinuria, then it is preeclampsia. Next, question number 13. A 24-year-old female at 32 weeks of pregnancy has blood pressure 160/116 and lab findings are significant with increased liver enzymes. That means LFT is deranged, there is increase in LDH, there is low platelets, okay, and peripheral smear is not been given to me. So is it hepatitis, is it HELLP syndrome, acute fatty liver of the pregnancy, or cholestasis? Liver enzymes raised, LDH raised and platelet decreases. This is HELLP syndrome, which means hemolysis, elevated liver enzymes and low platelets. So this is HELLP syndrome. Okay. 10 to 15% patients of severe preeclampsia can get HELLP syndrome as a complication. If you get such a finding, management is always termination of pregnancy. Fine. Yes, I will discuss how to differentiate placenta previa from abruptio. In placenta previa, there is painless, causeless bleeding and fundal height is equal to the period of gestation, whereas in abruptio placentae, there is always pain, cause and bleeding, and it is tender uterus and fundal height is more than period of gestation. So there is always some history, Dr. Abhishek, there is always some history of fall or trauma or PIH or some of the precipitating factor for abruptio. Abruptio means separation of placenta and there is internal bleeding in the uterus, whereas placenta previa is low-lying placenta and there is a fresh bleeding. So that is what is the difference. Okay. Next question. Question number 14. A 21 weeks of pregnant lady. Okay, there's a married female, she presented with 21 weeks of pregnancy and she is diagnosed with fetal malformation as meningomyelocele. How many doctors' opinion? It is 2023 Fmge exam question. How many doctors' opinion is required and whose consent is needed? 21 weeks of pregnancy. Okay, so this falls between 20 to 24 weeks. And when there is 20 to 24 weeks of pregnancy, 2 doctors' opinion is needed for MTP. Okay, and always the consent of the female is important if her age is above 18 years. So mother's consent and opinion of two doctors is must. This is according to the latest MTP Amendment Act 2020. Okay, so the upper limit has been increased up to 24 weeks. The MTP is legal. Okay, MTP is legal. Next question. Question number 15. Most common karyotype of a complete mole. Most common karyotype of a complete mole. Okay. Diploid with abnormal chromosomes maternal in origin. Diploid with abnormal chromosomes paternal in origin. Triploid or tetraploidy. So triploid or tetraploid is out of the picture because complete mole is always diploid. Okay, so complete mole. Okay, what happens in complete mole? This is empty ovum. Okay, it is fertilized with a sperm whose karyotype is 23X. After fertilization, this is monospermy. Okay, after fertilization, the chromosome of the sperms duplicates upon itself. Okay, so fertilization to hua hai, तो something will be formed. So it is grape like vesicles, which is complete mole. The karyotype will be 46XX, but this is abnormality against nature. So abnormal chromosomes are paternal in origin because ovum is empty and it does not contain any chromosomes. That is what is a pathology behind. Fine. Now next, question number 16. Identify the image. Is it Down syndrome, Turner syndrome, Klinefelter syndrome or androgen insensitivity syndrome? What is this? What do you see? There is no breast development, there is congenital webbing of neck, there is cubitus valgus deformity. So breast development is 0, there is congenital webbing of neck, there is cubitus valgus deformity, there is short fourth metatarsal, there is low posterior hairline. Low posterior hairline. So this is no other than Turner syndrome, and plenty of exams they have asked a question on Turner syndrome. What is the karyotype? 45X. So it is the most common cause for primary amenorrhea. There is absent sex chromatin. There is no bar body. What is the type of congenital heart disease in Turner syndrome? So type of congenital heart disease in Turner syndrome is bicuspid aortic valve, or it is coarctation of aorta. These patients are prone for osteoporosis. These patients are prone for autoimmune thyroiditis and diabetes later in life. Okay. Now question number 17. Again, this was an AIIMS PG question. AIIMS PG question, but they have asked this in Fmge exam 2020 as well. So identify what type of sterilization method is this. What type of sterilization method is this? Is it laparoscopic sterilization? Is it hysteroscopic sterilization? Is it mini lap or it is none? What are your answers? Dr. Jugal has written it mini lap. What is this? What do you see? This is Assure. That is a titanium coated coil which is put in the fallopian tube, and this is a hysteroscopic sterilization. Okay, Assure is a hysteroscopic sterilization and it permanently blocks the fallopian tube and there are no chances of recanalization. So this is Assure. Assure is a hysteroscopic sterilization. Okay, so do not forget to revise these questions again and again, because similar questions can be asked. Maybe the format of question can be changed. Okay, So that is why, just to boost up your confidence, I have come up with a 5 years FMG exam previous years questions. Okay, so just revise. Question number 18. Identify the anomaly. Is it unicornuate uterus, septate uterus or didelphus? Now, there are two Mullerian ducts. These two Mullerian ducts fuse to form a single uterus, cervix, upper vagina and the fallopian tubes okay, and lower vagina arises from urogenital sinus. Okay, so if this formation is not proper, that leads to Mullerian duct anomalies, and most common Mullerian duct anomaly is a septate uterus, and next is a bicornuate uterus. Septate uterus and bicornuate uterus are the important causes of female infertility, and they are also an important cause for recurrent abortions. Okay, the anomaly shown in this image is a unicornuate uterus. Okay, one cornua has not joined, or if it is joined, it is not going to form. Okay, it is not going to form any contribution in the formation of the uterus. So usually this anomaly on HSG is like this. Okay, this anomaly on HSG is like this. Okay, unicornuate uterus, which can be a cause of unilateral dysmenorrhea or a rare cause of ectopic pregnancy. Okay, next. Question number 19. A lady presented with complaints of foul smelling, greyish white vaginal discharge, and whiff test is done. Okay, whiff test was positive. In which type of vaginal discharge? Okay, which type of vaginal discharge we do the whiff test? Which type of vaginal discharge we do the whiff test? Okay, and there is another hint, clue cells are seen. So what is this type of diagnosis? This is bacterial vaginosis. This is bacterial vaginosis. And what is the drug for bacterial vaginosis? Bacterial vaginosis is caused by Gardnerella, and the drug is metronidazole. And also remember that Amsel's criteria is used for bacterial vaginosis, which also they have asked in FMG exam 2020, that Amsel's criteria is used for answer bacterial vaginosis. So the correct answer here is Gardnerella vaginalis, and the drug given for bacterial vaginosis is metronidazole. Drug given for bacterial vaginosis is metronidazole. Clear? Student, is it okay? Yes, I can read Dr. Mithu's answer, Dr. Harsh, Dr. Sandeep, Dr. Rahman, Dr. Panchal, Dr. Vamshi, Dr. Rudra, Dr. Kunal, Dr. Garima, all of you are very, very correct. This is Gardnerella vaginalis and the drug is metronidazole. I can read your chat in front of me. Now, question number 20. A lady with infertility undergoes laparoscopy for the purpose of assessment of her pelvic anatomy. The tubal patency chromotubation was done and involves pushing up a dye through a cannula into the cervix. Okay, so which type of dye is being used while you're doing a laparoscopic chromotubation? So it is a cannula. What is the name of the cannula? Name of the cannula is Leach-Wilkinson's cannula, which has also been asked in FMG exam. Name the cannula. It is Leach-Wilkinson cannula. And what is the dye being put through this cannula? And you can see chromotubation by doing a laparoscopy. So the procedure is laparoscopic chromotubation. The name of the cannula is Leach-Wilkinson cannula. Procedure is laparoscopic chromotubation. dye used is methylene blue. So the answer is methylene blue dye. Methylene blue dye. Name of the cannula is Leash-Wilkinson cannula. The procedure done for the tubal patency is laparoscopic chromotubation, which is a gold standard investigation. Clear? Next. So this is a normal HSG where we see the free spill of the dye, and this is laparoscopic chromotubation where we see the blue dye in the pouch of Douglas. This is laparoscopic chromotubation. Okay. Now next. Question number 21. Other name for outlet forceps. What is the name for outlet forceps? This is a short curved forceps. Short curved forceps, and you apply this forceps at the level of outlet. That means below +2 station. Okay. So the name of this forceps is Wrigley's forceps, and there is no screw in this. Which options are you asking? Which question you are asking, Dr. Strange? What all options? You want to ask saline, carbon dioxide, gentian violet? Or are you asking about this question? Keelant forceps was used for deep transverse arrest. It's no longer used. Das forceps was with axis traction device. This is no longer used, obsolete. Piper's forceps was used for after coming head of breech. Again, nowadays for a breech presentation, most of us prefer doing an elective cesarean section. Question number 19. Okay, I will answer. Okay, Candida and fluconazole. In Candida, there is a thick, curdy white vaginal discharge, and the drug is fluconazole, which is not fitting into this question. Number 2, trichomoniasis is a flagellated microorganism, and there is a greenish color vaginal discharge, and there are strawberry spots in the vagina. So again, this option does not fit into this. Gonococcus is a gram-negative cocci, and for gonococcus we don't use doxycycline, we use ceftriaxone. So according to this question, this is, like clue cells, whiff test is done for Gardnerella vaginalis, which is a cause for bacterial vaginosis. Now is it clear, doctor? Is that clear? Fine. So I'll proceed with rest of my questions. Question number 21, I have told you it is outlet forceps, which is name of the outlet forceps is the Wrigley's forceps. Keelant forceps was forceps rotation and extraction for deep transverse arrest, which happens in occipito-posterior position. That we don't use Keelant forceps nowadays. Then Das forceps, which is axis traction device, again we don't use, and Piper forceps is for after coming head of breech. So this is Das forceps. You can see there is axis traction device we don't use. This is Piper's forceps for after coming head of breech, and this is Keelant forceps, which is again not used. Fine. Is it okay? So next, question number 22. In which week the diabetic screening is done in the pregnant women? So we have almost been, discussing this in our classes, that a diabetic screening is done. Best is 24 to 28 weeks, because this is the time insulin resistance is high in pregnancy. Okay, so this is a very, very susceptible time to do a universal screening for diabetes in all pregnant ladies. Okay, this can be done by glucose challenge test, or this can be done by DIPSI criteria, Diabetes in Pregnancy Society of India, okay, where we give 75 grams of glucose and take the blood sample after 2 hours, and the cutoff value is less than 140 milligram per deciliter. So that is for universal screening of diabetes in pregnancy. Okay. Next, so this is how we are doing it. Diabetes in pregnancy study group of India. Fine. Now question number 23. We can extend MTP beyond 24 weeks in which condition? Okay. Rape, contraceptive failure, fetal malformation, or a minor. Okay. So the best answer according to me is a case of rape. Okay. Best answer according to me is a case of rape, and there is a medical board. If the pregnancy goes beyond 24 weeks, what should be done? That case is sent to the medical board. In the medical board, there is a gazetted officer that is selected by the state government or union territory. Then there is a gynecologist, there is a pediatrician, and there is a radiologist. These 4 people will decide that this case is to be taken for MTP or not. Okay. So this is latest MTP Amendment Act. Fine. Next question. Question number 24. Which of the following is a direct cause of maternal death? This is 2023 MCQ. Direct cause they have asked. Embolism, heart disease. Why they are not the direct cause? Because they are the medical diseases which is already persisting in that female. So it is not pregnancy related cause. Anemia. Anemia is again a medical cause, and anemia we call it as indirect cause of maternal death. Indirect cause of maternal death. So direct cause for maternal death is preeclampsia, because preeclampsia means hypertension developing during pregnancy. And here the culprit for various problems is the faulty placenta. Okay, because there is ischemia, inflammatory mediators which are released, which is causing the preeclamptic changes. Okay, as soon as the termination of pregnancy is done, the blood pressure of the pregnant lady will come down to normal within a week. Okay, so the direct cause of maternal death is preeclampsia, embolism, heart disease, anemia. These are the medical reasons for the death. So they will be considered as indirect cause for maternal death. It is not the direct cause. Fine. Now next, question number 25. In which of the following condition induction of labor is not done? In which of the following condition induction of labor is not done? Oligohydramnios, central placenta previa, hypertension, preterm rupture of membranes or premature rupture of membranes. Oligohydramnios, you can do induction of labor. Hypertension, that is preeclampsia or chronic hypertension, induction of labor is very much indicated, and in PROM also you can do induction of labor. But central placenta previa, you have to do an elective cesarean section at 38 weeks. Okay, elective cesarean section at 38 weeks. Yes, Dr. Mithu, Dr. Vamshi, Dr. Blue, Dr. Strange, Dr. Jugal, all of you are correct. So the correct answer is central placenta previa. Now next question, question number 26. A 25-year-old female presented with dysmenorrhea, menorrhagia, inability to conceive for 2 years, uterus is normal in size and there is bilateral adnexal mass. So patient presented with a classical presentation, dysmenorrhea, menorrhagia, infertility, and uterus is normal in size, but there are adnexal masses, bilateral adnexal masses. So I have already given you hint. What is this? Fibroid uterus, endometriosis, adenomyosis, endometritis. One more hint in the question. It is a young female. It is a young female with dysmenorrhea, menorrhagia, infertility, bilateral adnexal masses. It is no other than endometriosis. Adenomyosis means presence of endometrial glands in the myometrium. Adenomyosis is occurring in a 40-year-old female. Adenomyosis never cause infertility. Okay, so young female, young lady with infertility, with congestive dysmenorrhea, with heavy periods and adnexal masses which is bilateral is endometriosis. Clear cut. And what is the gold standard investigation in endometriosis? The gold standard investigation in endometriosis is laparoscopy. And what is the most common symptom of endometriosis? Answer is pain. Question asked in Fmge exam 2018. Question asked in Fmge exam 2018. And what is endometriosis? Question asked in 2018. How come 3 questions in 2018? Because it is a twice a year exam. That is why 3 questions from this topic. Okay, so pain. What type of pain? Answer is congestive dysmenorrhea. What type of pain? Congestive dysmenorrhea. So most common symptom, pain. What type of pain? Congestive dysmenorrhea. It's occurring in young female. Dysmenorrhea, menorrhagia, infertility, adnexal masses, uterus normal, or there is tenderness in pouch of Douglas because of pouch of Douglas endometriosis. Gold standard is laparoscopy because you can do fulguration of the cyst, you can do ovarian cystectomy, you can do adhesiolysis. Now why there is infertility in endometriosis? Because of immobilization of fallopian tube due to adhesions. So fallopian tube, uterus, ovaries, they are entangled in adhesions leading to infertility. Fine. Next, question number 27. Hyperestrogenic conditions are all except. This is again 2023 Fmge exam question. What's your answer? Hyperestrogenic conditions are all except. What's your answer? Ovarian cancer, low BMI, tamoxifen use or endometriosis. What will you mark? Low BMI is always like hypoestrogen condition. Tamoxifen we use it for a breast cancer, but it increases the risk of endometrial cancer because in breast, but increases the risk of endometrial cancer because in the breast tissue it acts as an antagonist, estrogen antagonist, and in uterus it acts as an estrogen agonist. Endometriosis is again hyperestrogenic stage. Ovarian cancer, there can be hyperestrogen like if there is endometrioid type of endometrial cancer. So low BMI is the answer to this question. Now question number 28. According to WHO, maternal death is. According to WHO, the maternal death is occurring after 24 hours, within 6 weeks after delivery, or maternal death within 2 weeks after delivery, or it is 12 weeks after delivery. So correct answer is within 6 weeks of delivery. Okay, within 6 weeks of delivery, that is maternal death. Okay, so definition is annual number of female deaths due to any cause related or aggravated with pregnancy within 42 days of termination of pregnancy. Okay, so that is maternal death. So within 6 weeks of delivery is maternal death. So question number 29. How many weeks of gestation age uterus corresponds to post delivery? So uterus corresponds to post delivery. So this is 20 week size. Immediate post delivery it is 20 weeks size. There is one more question that following delivery, what is the weight of the uterus just immediately after delivery? So answer is 1000 grams. Okay, so the answer is 1000 grams. Next question, question number 30. A pregnant woman at 32 weeks of pregnancy comes to emergency with severe pain, abdomen, bleeding. On examination, there is tender uterus, fetal heart rate is absent. Okay, so pregnant lady coming up with pain, with bleeding, fetal heart rate absent, and there is tender uterus. This condition. Okay, so in the uterus there is placenta, and what has happened? There is premature separation of placenta has taken place, and there is formation of a retroplacental clot. When you touch this uterus with your hand, there will be tenderness, and since there is so much of blood loss has taken place in this condition, okay, so fetal heart rate is absent. So what is the correct answer? You can write down in the chat box. Placenta previa, abruptio placentae, rupture uterus or polyhydramnios. It cannot be rupture uterus because there is no reason given in the question that it will be a rupture uterus. Patient is not in shock, there is no scar, that means it is not a post cesarean pregnancy, neither it is a good size baby, nothing is written, so it is not rupture uterus. It is not fitting into polyhydramnios as well. It is not a placenta previa because placenta previa there will not be any pain, there will not be any tenderness. So this is abruptio placentae. Okay, it may be a cause, it may be a high blood pressure which is causing vasoconstriction and separation of placenta. So yes, I can read your answers. Dr. Sinha, Dr. Strange, Dr. Rajat, Dr. Kunal, Dr. Harsh, Dr. Sakshi, Dr. Rajat, Dr. Ashish, all of you have written it very correctly. The answer is abruptio placentae. Next, question number 31. In a 3 swab test, middle swab is stained blue. What is your diagnosis? This is Jones dye test which is done for urinary fistulae. Urinary fistulae. Okay. So we put in a methylene blue dye into the urinary bladder, and we keep 3 swabs in the vagina. Swab number 1, swab number 2, swab number 3. If the lowest swab is stained blue, okay, because we have filled in a blue dye into the bladder, this is urinary bladder, okay, and if there is a communication between the bladder and the vagina, okay, or between the urethra and the bladder, or between the ureter and the vagina, then we are doing this test. If the lowermost swab is stained blue, then this is ureterovaginal fistula. This is not in the option. They say it is a middle swab which is blue. If middle swab, cotton swab is blue, then this is vesicovaginal fistula, which is there in the question. Okay. If the uppermost swab is wet and smell of urine, then it is ureterovaginal fistula. Ureterovaginal fistula. So in this question, they have said the middle swab is stained blue. So which type of fistula? It is vesicovaginal, which we normally call it as VVF, vesicovaginal fistula. Most common cause of vesicovaginal fistula in the countries like India is obstructed labor. And when do you repair a vesicovaginal fistula? caused due to obstructed labor? Answer is after 3 months. You repair it after 3 months. So if the lowermost swab is stained blue, it is urethral fistula. If it is middle swab stained blue, it is vesicovaginal. If it is uppermost swab is wet and smell of urine, then it is ureter and vaginal fistula. Clear? So this was the question. So the answer was vesicovaginal fistula. So the answer was vesicovaginal fistula. Now next, question number 32. Hormone in molar pregnancy. That is a clear-cut question. GnRH, FSH, HCG or LH. What's your answers? What are your answers? Hormone in molar pregnancy. I can read your answers. Hormone in molar pregnancy, what is it? GnRH, FSH, HCG or LH? Yes. Dr. Kunal, you have marked it very correctly. Dr. Mithu, Dr. Jugal, Dr. Rawat, Dr. Harsh, Dr. Sheikh, Dr. Ajay. Yes, I can read your answers. It is beta HCG. I have already discussed a similar question before. So next, question number 33. Molar pregnancy is usually diagnosed early in pregnancy due to bleeding abnormal features of ultrasound higher than usual. Now, which hormone is responsible and what do you find in this ultrasound image? What is this ultrasound image? Ultrasound image is showing snow storm appearance. So, why these features occurring? This is a case of a molar pregnancy. This is a case of a molar pregnancy, and this all features occurs because of HCG. Okay, this I have already discussed. Next, question number 34. This is very important question, and this is a question of 2020 August Fmge exam. Which of the following peak is responsible for ovulation? Okay, so just read, just see the options. Peak A is a LH peak. Peak B is the FSH peak. Peak C is the estradiol peak, and peak D is the progesterone peak. Now, which peak is responsible for ovulation? What's your answer? Which peak is responsible for ovulation? That ovulation is going to happen. So, I can read your answers. Dr. Kunal has written it. Peak A, that is LH surge or LH peak. Dr. Jugal, Dr. Medico, Dr. Vamshi, Dr. Krishna, Dr. Ajay, Dr. Rahman, Dr. Sinha. Yes, I love this interactive session and welcome you all to this session. Those who have just recently joined, welcome you all. Yes, Dr. Sheikh. This is peak A, that is LH surge or LH peak. LH peak occurs 10 to 12 hours before ovulation. So the correct answer is peak A. Fine. Next question. This was my question number 34. Now question number 35. This is 2023 Fmge exam question. Okay. So I have compiled the questions myself because every session I am teaching the Fmge batch along with, like I am taking for PG classes as well. So students, after giving the exam, they keep on sending the questions to me. So that is how I have made my question bank. From this question bank, I have compiled this today's session. Okay. I don't understand your smiley, Dr. Strange. I don't understand. Is it that smiley of appreciation or smiley of shock? Okay. So this is anencephaly craniorhynchiasis. Okay. Now next question. Question number 36. Identify this maneuver. Is it a Pinard's maneuver, Lovset's maneuver, Ridgen maneuver or Morrissey's Milliviet technique? What do you find in this maneuver? What do you find in this maneuver? Pinard's, Lovset's, Ridgen or Morrissey-Smiley-Viet technique? What is the maneuver? I can read your answers because it is going to be an interactive session. Okay, Dr. Strange. Please, I am no one to comment upon your this, but you know, like I was surprised by your smileys. It was looking like shocking. So that is why students, you know, like this will be a quick revision and it is a very crisp and concise, that is why I am not discussing a question in very detail, because otherwise I have to limit the number of questions. I want to give you maximum questions of last 5 years. Yes, this is a Ridgen maneuver. Ridgen maneuver is that with one hand you control the, you know, like flexion and then head is being delivered as extension. This maneuver is being done when you are conducting a normal vaginal delivery. This is to prevent, the aim is to prevent the perineal tear in the mother, and to conduct a smooth vaginal delivery. By maintaining the flexion of the fetal head and delivering the fetal head by extension. So this is a Ridgen maneuver being done in the normal vaginal delivery. Next, just have a look at this. This is Lovset's maneuver to deliver the breech with extended arms. This is Morrissey-Smiley-Viet technique to deliver after coming head of breech, and this is Pinard's maneuver to deliver breech with extended legs. So this is Lovset's, this is Pinard's, and this is Morrissey-Smiley-Viet technique. Which option? Morrissey-Smiley I have just explained. This is jaw flexion. Okay? This is jaw flexion and shoulder extraction after coming head of breech. Fine. Now next question, question number 37. Identify, I don't know the other options. So this is clear cut a Veery's needle while you are doing a laparoscopy. Before that you have to create a pneumoperitoneum. So this Veery's needle is used. Question number 38. Which is not used as an emergency contraceptive? Which is not used as an emergency contraceptive? Ulipristal 30 mg, LNG 0.75 milligram 2 tablets in 24 hours, combined OCPs 2 tablets and repeated after 12 hours, LNG single dose. So which is not used? LNG pill is not been given twice, it's a single dose which has been used. So most commonly used emergency contraceptive in India is LNG pill 1.5 milligram single dose within 72 hours of unprotected coitus. So LNG pill is being used. Otherwise, what is the best emergency contraceptive is copper T to be applied within 5 days of unprotected coitus. Ulipristal is also used, but it is not available in India. Okay. Next, question number 39. Drug used in chemoradiation in cervical cancer. Cisplatin, doxorubicin or carboplatin. What's your answer? Which is a radiosensitizer drug? I used to teach my students which is a radiosensitizer drug. This is a repeat question. It has been asked in 2012 Fmge exam as well. Now it was asked again in the Fmge exam. So which is a radiosensitizer drug used in cancer cervix. So answer is cisplatin. Cisplatin is a radiosensitizer drug used in cancer cervix. Now question number 40. Question number 40. In which trimester beta HCG, unconjugated estriol, alpha fetoprotein and inhibin test is done? So if you are doing 4 tests, that is called as quadruple test. In quadruple test, we do quadruple test between 16 to 18 weeks. Okay, so it is done in the second trimester. Okay, so we do alpha fetoproteins, beta HCG, estriol and inhibin A. Alpha fetoprotein falls, HCG rises, estriol decreases, inhibin A rises. This is a marker for trisomy 21, which is Down syndrome. So quadruple test is done in the second trimester. Clear? Now question number 41. 5th postpartum day, a woman develops low mood, sadness, irritability, restlessness, crying, mild depression, reduced sleep. Now when in the question the hint is 5th postpartum day, her mood is off, she is crying, she is sad, she is irritable, she has depression, okay, and reduced sleep, then this is postpartum blue. Postpartum blue. So detail you can have a look in your psychiatry classes. Fine. Next. Question number 42. A woman with postpartum hemorrhage was treated with ergometrin, oxytocin, still she is bleeding and it is not stopped. Which prostaglandin derivative you are going to give? When your first line drugs, that is uterotonics. Uterotonic means the agents that contract the uterus to prevent postpartum hemorrhage. If your first line uterotonics fail, then which is the next line of drug, that is prostaglandin analogues. So which type of prostaglandin are you going to use? Misoprostol, that is prostaglandin E1, or it is carboprost, that is prostaglandin F2 alpha, or it is dinoprostol, that is prostaglandin E2, which is available as gel. First of all, gel is not used because that is used for induction of labor. Induction of labor. So this is out of the question. Now from carboprost or misoprostol, the recommendation is start with misoprostol and the dose of misoprostol, that is misoprostol tablet, is you give 800 micrograms sublingual route. So this is what is recommended. If you can't give it sublingual route, then 1000 micrograms per rectal. But this sublingual route is fair enough, the absorption of the drug is very faster and it used to cause the contraction of the uterus and minimize the blood loss. So misoprostol is the answer. Okay. Next, question number 43. 47XXY, which is wrong statement? Question from 2023 Fmge exam. Decreased FSH, azoospermia, decreased testis size or hyalinization of Sertoli cells. So this is Klinefelter syndrome. Klinefelter's syndrome. Klinefelter syndrome is 47XXY. There is false sex chromatin. These are tall males with gynecomastia, hypogonadism and infertility. Tall males, gynecomastia, hypogonadism and infertility. So FSH will be down. This is true. Azoospermia, true. Azoospermia correct, decreased testis size, hyalination of Sertoli cells correct. So wrong statement is decreased FSH. Their FSH levels are increased. Okay, so the wrong answer is decreased FSH. Okay, they have hypogonadism. Okay, so they are infertile males. Fine. Next. Question number 44. Okay. Male had infertility and respiratory infection. Most infected part. What's your answer? Ciliary dyskinesia or cystic fibrosis? So this is ciliary dyskinesia. Okay. So this is Carter-Jenner syndrome, which is autosomal recessive disorder characterized by frequent respiratory tract infections and infertility. You can read it in your pathology. So question number 45. A girl with PCOS, which type of test is being done? So this is, like when I was discussing the recall session of 2023 Fmge exam, even, like the options given to us was, like very confusing. What was the exact frame of the question, I don't know. But if they have asked which is the first test to be done in PCOS patient, then it is testosterone levels. If what is the total hormonal profile, then we do check FSH-LH ratio as well. So students are the best guide to tell us, because they are the ones who have attempted the questions in the exam, and we prepare our recall sessions or like this kind of sessions live according to the questions provided to us. Okay, so you are the better judge. Those who have given the exam, they can tell us better. Okay, if the first investigation to find out hirsutism, it is like serum testosterone level which is being done. So I switch over to the next question. Question number 46. McCall's scaldoplasty is done for, this is a question of genital prolapse in gynecology, where for cystocele when the bladder is prolapsing in vagina, rectocele when rectum is prolapsing, enterocele or pouch of Douglas prolapsing, that is called as enterocele. Okay, so this surgery is done for enterocele repair. Fine. Next question. Question number 47. Identify the condition. This is 2020 Fmge exam question. Condyloma lata, molluscum contagiosum or condyloma acuminata. This is like overlap question between gynae and dermatology. Actually, if you frankly ask me, it is a question of dermatology, because if you get such patient, we do refer to the venereal disease specialist. Okay, so what is your answer? Come on, write down in the chat box. Yes, I can read your answer, Dr. Sakshi, Dr. Krishna. What about others? Dr. KK, Dr. Mithun. Yes, this is condyloma. Okay, genital warts. Genital warts are HPV 6 and 11. So you read this in detail in your dermatology classes. Next question. Question number 48. According to recent updates of MTP Act 2021, registered medical practitioner can terminate the pregnancy up to how many weeks? What's your answer? 18, 20, 24 or 26? What's your answer? Doctors, what is your answer to the next question? I can read Dr. Ajay's answer. What about others? Dr. Mithu, Dr. Muskan, Dr. Rudra, Dr. KK, Dr. Strange, Dr. Garima, Dr. Wasif, Dr. Kunal, Dr. Rudra, Dr. Rahman, Dr. Saeed, Dr. Medico, Blue Panther, Ajay, Sheikh. So yes, all of you are correct. Answer is 24 weeks. Next question. Question number 49. Which of the following is an absolute contraindication for IUCD insertion? History of previous PID, unexplained vaginal bleeding, previous ectopic pregnancy or HIV positive status? Which is an absolute contraindication for IUCD insertion? What's your answer? What's your answer? Read it very, very carefully. It is very, very confusing. I can read Dr. Kunal's, Dr. Saul, Dr. Rajay, Dr. Vamshi, KK. Yes, this is unexplained vaginal bleeding is the correct answer. Unexplained vaginal bleeding is absolute contraindication. Why? Because any type of abnormal bleeding can be a presentation of underlying genital cancers. Number 2. Copper T itself causes bleeding because it needs 2 to 3 months to set in. So, we will not be able to differentiate the cause of bleeding. That is why if it is undiagnosed vaginal bleeding, IUCD insertion is absolutely contraindicated. So, we are towards the half century and this is question number 50. What is recommended dose of folic acid in a female with a history of neural tube defects in the last pregnancy? Now, there is a lot of confusion in this question. That means you need to give a therapeutic dose of folic acid. You need to give a therapeutic dose of folic acid and this is to be started 2 to 3 months before conception and should be continued in the first trimester of pregnancy. Should be continued in the first trimester of pregnancy. Yes, you are absolutely correct. The answer is 4 milligrams. So, you started few months before. Thank you, Dr. Kushal, for appreciating me. I am amazed. I am very happy with your reply. So, it is 4 mg and once the first trimester is over, you combine it with, replace it with iron folic acid tablet where that will be 60 milligram of elemental iron plus 0.4 milligram of folic acid. This is to be given in the second trimester, in the third trimester and in the lactation. For the first trimester, 4 milligram of folic acid to be given. Next, question number 51. Maximum amniotic fluid is seen in which gestation age? 20 weeks, 28 weeks, 32 weeks, 36. So, answer is 32 weeks. The amniotic fluid is 1 liter, that is maximum. This is according to the Williams textbook of obstetrics. Okay? And at term pregnancy, the amniotic fluid starts decreasing. Next, they have also asked in Fmge exam, what is the color of amniotic fluid at term pregnancy? What is the color of amniotic fluid at term pregnancy? It is pale straw colored. Pale straw colored. Okay. Next, question number 52. Minimum antenatal visits. This is minimal antenatal visits. So, according to this option, answer is 4. Question number 53. Cardiac output comes to normal after how many days following delivery? So, the answer is 10 days following delivery. Next, question number 54. Fmge exam 2022. In colposcopy, which color of the filter we are using? Is it red, green, blue or orange? Which color filter we are using? Yes, I can read your answers. What's your answer? Yes, it is a green color filter which is used in colposcopy. Colposcopy is a confirmatory test for cancer cervix or dysplasia cervix, and we use 3 to 5% acetic acid while you are visualizing the cervix, and then we use it green filter to identify the abnormality and we can take the biopsy. Fine. So, question number 54. So, this is a green color filter during colposcopy. This is a colposcopy image using a green filter. This is when you are applying villi visual inspection under Lugol's iodine, and this is when you are doing VIA, visual inspection under acetic acid. So, the most cost effective method for screening in low resource countries like India is VIA, very cost effective method. Okay, what do you see in the abnormal areas? It is aceto-white areas. Okay, aceto-white areas. Clear? Next, question number 55. Antihypertensive drug of choice in pregnancy: lisinopril, methyl dopa, hydralazine or labetalol. What is the antihypertensive of choice in pregnancy? What's your answers? Quickly, come on. Yes, you are very right. Most cost effective is VIA. Now, next question I have asked, which antihypertensive is choice in pregnancy? What's your answer? Yes, it is labetalol. Labetalol is alpha plus beta blocker. 3 drugs, latest, according to the textbook Williams, latest 3 drugs are in use or recommended safe in pregnancy, that is labetalol, hydralazine, nifedipine, and even these are the first line drugs, and then also methyl dopa is also considered as safe antihypertensive drugs in pregnancy. Fine. Next, question number 56. A lady passes urine while coughing or laughing. Name the type of urinary incontinence. Urge incontinence, urethrovaginal fistula, reflex incontinence or stress urinary incontinence. Whenever a lady laughs, coughs or strains and she urinates, that is a feature of stress urinary incontinence. So, whenever she coughs, laughs or strains, she urinates. This is a feature of genital prolapse because of bladder neck prolapsing in the vagina. And which is the best treatment for stress urinary incontinence is TOT, that is transobturator tape. Transobturator tape. Fine. Next, question number 57. Size of the Carman's cannula at 8 weeks of pregnancy for suction evacuation. Whatever is the weeks of pregnancy is equal to the size of the cannula, is equal to the size of the cannula. So, you can use the same number or a number less. So, answer is 8 weeks. Okay. Question number 58. Identify the instrument. Is it a dilator? Is it a curette? Is it a sound or it is a vaginal wall retractor? What is it? This is a curette. This is to perform DNC. This is to perform curettage after MTP. Okay. So, this is a curette. Curette has got a sharp end and it has got a blunt end. When you are doing the curettage in a pregnant uterus, then maybe like a blunt end can be used. If it is an obstetric case, we use a blunt end. If it is a gynae case, we use a sharp end. So, remember this. So, this is a curette. Fine. Next question. Question number 59. What is the reason of abdominal pain in the mother when she is breastfeeding? You must have seen in the post-delivery room, the female is complaining like, doctor, whenever I am feeding my child, I am feeling lot of pain. So, what is the reason for pain? Now, the hormone which has been released while she is breastfeeding, there is a suckling reflex. While she is breastfeeding, there is a suckling reflex by the baby, and this suckling reflex leads to the release of oxytocin from the mother. Oxytocin is going to act on the breast tissue and cause milk ejection, and it is going to act on the uterus. Okay, and this hormone prevents postpartum hemorrhage. So she is feeling the pain. So which hormone is responsible? This is responsible hormone here is oxytocin. Fine. Next, question number 60. Which of the following is the treatment of decubitus ulcer in uterine prolapse? Now, what is a decubitus ulcer? When cervix is lying continuously outside, the venous return gets obstructed, so there is venous congestion. There is venous congestion leading to formation of an ulcer. Leading to formation of an ulcer at the most dependent portion of the cervix. This is called as decubitus ulcer. So what is the treatment? Treatment is reposition of cervix back into vagina and doing glycerin acreflavin packing. Glycerin acreflavin packing. Okay, so glycerin is, friends, glycerin is hygroscopic. Glycerin is hygroscopic, absorbs water and reduces edema. It will reduce the edema at the level of cervix, and acreflavin is antiseptic. So what's your answer? Are you going to give antibiotics? Are you going to do packing with a tampon dipped in glycerin acreflavin solution? Are you going to do a laser ablation, or you're going to give a cryotherapy? So I have already told you the answer, and I can read the correct answers. Dr. Sandeep, Dr. Rahul, Dr. Vamshi, Dr. K, Dr. Rajat, Dr. Kushal, Dr. Rudra. So the correct answer is packing. Very correct. Fine. Next, question number 61. Causative agent for CIN3 and cancer cervix. I think it is a very straightforward question. What have you marked as your answers? What have you marked? Yes, you are all correct. What have you marked for this particular question? Causative agent for CIN3 and cancer cervix. The correct answer is HPV 18, because the most common cause for cancer cervix or dysplasia is HPV 16, 18. Since 16 is not given, so we will mark HPV 18. Question number 62. A patient underwent radiotherapy for cancer cervix. Which organ in the pelvis is most radiosensitive? Uterus, urethra, ovary and urinary bladder. What is your answer? I can read your chat. What's your answer? Yes, I have seen your answers for the previous question. But what about the present question? Which of the following is most radiosensitive organ in female genital tract? Yes, ovary is highly radiosensitive. That is why if radiotherapy is given for any ovarian tumor in a young female, we abandon it and we prefer doing the surgery. Such an example is germ cell tumors of the ovary. Like dysgerminoma is a germ cell tumor, but we cannot give radiotherapy in a young female because it will cause ovarian destruction. Fine. Next, question number 63. It's a straightforward question. Lining epithelium of fallopian tubes. What's the answer? Lining epithelium of fallopian tubes. It is columnar ciliated. What is the lining epithelium of vagina? Stratified squamous, non-keratinized. Stratified squamous, non-keratinized. Lining epithelium of ovary, cuboidal. Lining epithelium of uterus and cervix canal, it is columnar epithelium. Okay, so this is a very straightforward question. Next, question number 64. Which of the following condition is an absolute contraindication for breastfeeding? HSV in the mother, galactosemia, CMV or HCV? What's your answer? Breastfeeding is absolutely contraindicated in galactosemia. Next. Question number 65. Ultrasound image of uterus shows snowstorm appearance, which I have already discussed in the previous questions. Now, what is your diagnosis? What is your diagnosis? If an ultrasound image shows snowstorm appearance, what is your present diagnosis? It is usually the hydatidiform mole, which is mostly the complete mole. Okay, which is mostly the complete mole. Next, question number 66. Pelvis associated with persistent occipito-posterior position. Is it android, anthropoid, platyploid or gynecoid? What's your answer? What's your answer? What have you marked? Persistent occipito-posterior. The correct answer, friends, it is seen in anthropoid pelvis. Persistent occipito-posterior position. Android pelvis is deep transverse arrest, most common. Platyploid DTA never occurs, and in persistent occipito-posterior or anthropoid pelvis, phase to delivery, phase to pubis delivery is also common. Gynecoid pelvis is a normal pelvis. Okay, so answer to this question is anthropoid, where phase to pubis delivery is more common. Fine, persistent occipito-posterior. Now question number 67. Question number 67. A female had previous history of cesarean section and prolonged labor. She is hypotensive, fetal heart rate cannot be heard, fetal parts palpable superficially. What is your likely diagnosis? There is a history of cesarean section, means there was a previous cesarean section being done. Okay. Now, she is presently in the pregnancy and there may be uterine contractions and there is like fetal parts felt very prominently and fetal heart rate is absent. It is previous cesarean section with present pregnancy and blood pressure is down. That means she is in shock. It is a dead baby and there is uterine scar and fetal presenting parts felt very, very prominent. What do you think is the answer to this question? I can read Dr. Blue, Dr. Abhishek, Dr. Jugal, Dr. Vasif, Dr. Kushal, Dr. KK, Kunal, Rudra, Ajay, Abhishek, Strange, Sandeep, Kaul, Arman, Abhishek, Jugal, Vamshi, Pratik, all of you are 100% correct. It is a uterine rupture. So this patient first of all should have checked what was the indication of a previous pregnancy, what is the present pelvic assessment, what is the size of the baby, what is the presentation, and by ultrasound what is the previous scar thickness. And as far as possible, if it is a very, very safe or institution where is a facility for an earliest indication for cesarean, only then a short trial of labor can be given. So this was a neglected case where rupture uterus has already occurred and patient has gone into hypotension. Management is immediate laparotomy and cesarean, as well as even if it is a baby dead, and repair of the uterus. If repair is not possible, then hysterectomy as a life-saving measure. Fine. Now, next question number 68. 32 weeks of pregnant lady complains of vaginal bleeding. On examination, uterus is tender and fetal heart sounds are absent. Tender uterus, vaginal bleeding, fetal heart rate absent. What do you think is a diagnosis? Placenta previa, abruptio placentae, rupture uterus. What's your diagnosis? Yes, I can read your answer. Yes, this is abruptio placentae. It's a clear-cut question, and similar question I have already discussed in the previous questions. Okay, so let us proceed further. Question number 69. A pregnant female visits antenatal OPD for the first time at 18 weeks. Fundal height is up to 16 weeks. Obstetrician advises ultrasound. What is likely to be seen? Fundal height less than the period of gestation. What's your answer? Fundal height less than the period of gestation. What's your answer? Okay, Dr. Abhishek, you are almost attending all the questions very correctly. Yes, Dr. Abhishek Sankla, you are almost writing the answers very correctly. Now, what is the answer to this question? Dr. Abhishek, I am asking you now. I can read the answers. Dr. Kunal, Rudra, Vasif, Abhishek, Kiranjot, Vamsi. Yes, this is renal agenesis. Fundal height less, so that will lead to oligohydramnios. Okay, next question number 70. A 25-year-old para 1 L1 delivered 12 weeks back gives a history of continuous bleeding per vaginum. There's a history of DNC done in some private hospital. What is the reason? She has delivered 3 months ago. But why she is presenting with bleeding now? If 3 weeks have passed, secondary PPH means postpartum hemorrhage occurring after 24 hours of delivery, within 12 weeks of delivery. That is secondary postpartum hemorrhage. So, students, this is not PPH. DIC never presents like this. DIC, there is a preceding history of septic abortion or abruptio placentae or dead fetus, which is not there in this question. So, it is not DIC. It is not normal lochia, because normal lochia is vaginal discharge after delivery. It is 21 days. But this is almost 3 months has happened. So, that means this has led to gestational trophoblastic neoplasia. So, the correct answer to this question is C. So, this has developed GTN, gestational trophoblastic neoplasia, and after a normal delivery, it is choriocarcinoma. But here, if it is a not, it is written as a normal delivery only. So, after normal delivery, if a GTN is developing, then most likely it has happened as choriocarcinoma. So, it is choriocarcinoma. Fine. So, such questions are also expected in FMG exam as well. Next, question number 71. 25-year-old primigravida female is on lithium treatment for some psychiatric illness for last 2 years. Most common anomaly seen in the fetus whose mother is on lithium. What's your answer? PDA, VSD, neural tube defect, abstain anomaly. It's a very, very simple question. This you read in your 3rd year MBBS. What's your answer? I can read your answers. Dr. Vasif, Dr. Kunal, Dr. Jugal, Rudra, Rajat, Ajay, KK. Yeah, Dr. Rudra, I've said your name. Dr. Mir, Dr. Sakshi, Ajay, Abhishek, Sankla, Dr. Rahman. Yes, all of you are correct. This is abstain anomaly. I am very happy with your responses. You are all writing correct answers. Very good. Is it that I am taking up this session? You are enthusiastic or you already know these questions? Write down something in the chat box at least. Chalo, let's proceed with a further question. Question number 72. 26-year-old female with mechanical valve on warfarin therapy has a pregnancy test positive. What is the best advice to her? What's the best advice? Continue warfarin throughout the pregnancy? Replace warfarin with heparin in pregnancy? Discontinue all anticoagulants in pregnancy? Warfarin is contraindicated in pregnancy and lactation. What is your best advice? It is replace warfarin with heparin. Okay, so for the first trimester, we give heparin. From 12 to 36 weeks, we give warfarin. From 36 weeks to delivery, heparin. After delivery, again warfarin. So why warfarin is not given in the first trimester? Because warfarin causes teratogenic effect. It is teratogenic. So warfarin is not preferred in the first trimester of pregnancy. As soon as the pregnancy is been diagnosed, we replace it with heparin. Fine. Next. Question number 73. Complication associated with IV bolus injection of oxytocin. IV bolus injection of oxytocin. Hypoglycemia, hypotension, hyperglycemia or hypertension. So IV oxytocin, if given bolus, it can cause hypotension. Fine. Next. Question number 74. False statement regarding the instrument given in the image. What is this instrument? This is a vacuum aspiration syringe. MVA, manual vacuum aspiration. Okay, its capacity is 65 ml. This is correct. It creates a pressure. That's correct. Does not lead electricity. Correct. But it cannot be done if MTP is up to 12 weeks. That is wrong answer. That is wrong answer. Fine. एग्जाम में कुछ नहीं बदलने वाला है यार. गाइनी ऑप्स बहुत अच्छे से करो और बाकी सब्जेक्ट्स भी अच्छे से करके जाओ. That is what. Use your presence of mind and friends. Again and again I have been telling in my sessions, always make your preparation best for the first paper. Because अगर आपने first paper में गड़बड़ कर दिया तो second आप कितना भी अच्छा करोगे, आप पासिंग से काफ़ी दूर हो जाओगे. सो सबसे पहले आपको अपने प्री एंड पैरा क्लिनिकल्स पेपर 1 बहुत अच्छा करना है. देन पेपर 2 विल ऑलवेज गिव यू अ बोनस. ओके, खाली पेपर 2 से क्लिनिकल से कभी एग्जाम नहीं निकलता. हमेशा प्री एंड पैरा सबसे पहले करना है. क्लिनिकल आप अच्छा कर ही लेते हो, बट प्रॉब्लम कहाँ आती है? प्री एंड पैरा क्लिनिकल्स. सो डू योर पेपर 1 वेरी परफेक्टली. ठीक है, पेपर 2 तो आप कर ही दोगे. ठीक है. नेक्स्ट क्वेश्चन नंबर 75. सो G4P0A3, दैट मीन्स दिस इज अ बैड obstetric history. Fourth gravida, 3 abortions, 24-year-old female presents at 22 weeks with the 3 mid-trimester abortions. Mid-trimester abortions, most common cause for mid-trimester recurrent abortions is cervical incompetence. Next causes can be uterine anomalies. Another causes can be APLA, antiphospholipid antibody syndrome, and most common cause for first trimester abortions is chromosomal. Okay, so cervical length is 20 mm, and what is the most probable cause for recurrent abortions? Most common cause for recurrent abortions: uterine anomalies, chromosomal anomalies, cervical incompetence, or hormonal imbalance. What's your answer? Yes, I like the answer of Dr. Sheikh, Dr. Kushal, Dr. Rahul, Dr. Sakshi, Dr. Vasif, Dr. Rudra, Dr. Sandeep. Are you writing the answers for this particular question? Dr. Rupinder, Dr. KK. So this is cervical incompetence. And what is the treatment for cervical incompetence? Cervical encerclage operation, that is McDonald stitch, followed by tocolytics, uterine relaxants. Best tocolytic agent, nifedipine. Best tocolytic agent, nifedipine. Clear? Next, question number 76. 24-year-old prime gravida is having pain. Her cervix is 1 centimeter dilated, 20% effaced. After 10 hours, same finding. Fetal heart rate is regular. And what is your next step in management? Start oxytocin, do ARM, do cesarean, sedate the patient. What's your answer? What's your answer to this question? What are you going to do? Yes, I agree. Dr. Rahul, very correct. I am going to sedate the patient. Why the answer cannot be oxytocin, ARM or cesarean? Because is she on antihypertensive or she is having PIH? No. Is she having abruptio placentae? No. Is it post-dated pregnancy? No. So I am not going to give any augmentation or induction of labor. Just simply sedate the patient. Fine. Next. Question number 77. 23-year-old female, prime gravida, 19 weeks of gestation for the first time. She has no significant medical history. Her family history is significant for diabetes running in the family. ECG is normal, urine analysis is normal, fasting blood sugar is 126. Glycosylated hemoglobin is 6.5. What is your likely diagnosis? 19 weeks. So this is pre-gestational diabetes. Fasting is high. Okay. This is pre-gestational diabetes. So you can go through the criteria for like gestational diabetes. I have already explained. Now this is International Association of Diabetes in Pregnancy Study Group. 75 grams of glucose you give and you take fasting 1 hour and 2 hour sample, 92, 180, 153. This is important and they have already asked in the exam. Or another one is fasting more than 126 or 2 hour postprandial is more than 200. Then that is overt diabetes, or random is more than 200. So this is fitting into this category. So this is pre-gestational diabetes. Next, question number 78. Identify the swelling. A female presented at 22 years of age, and in the examination, local examination, there is a swelling. So is it a cystocele, is it a Gartner's cyst, is it a cervical polyp, or is it a Bartholin cyst? What's your answer? What's your answer? Write down in the chat box. Yes, this is a Bartholin cyst. And Bartholin cyst, what is the treatment? Treatment is marsupialization. Treatment is marsupialization. Cystocele is along with genital prolapse, that is a bladder neck prolapsing. Then Gartner's cyst is not like this. Cervical polyp again is not like this. So this is a Bartholin cyst. Next, question number 79. Most cost effective method for cervical cancer screening. What did I tell you? Pap smear, HPV DNA testing, VIA or colposcopy. Colposcopy is a confirmatory test. When there is abnormal pap smear, then you do colposcopy. Okay? What's your answer? Cost effective method for cervical cancer screening is, what's the answer? Yes, Dr. Rudra, Dr. Sandeep, Dr. Buzz, Dr. Vamshi, Jugal, Vasif. The correct answer is VIA. If it is a cost effective, then most cost effective is VIA, visual inspection under acetic acid. Okay, and the abnormal area in VIA is acetovite areas, acetovite area. Okay, but what is the latest WHO guideline which should be the best primary test for screening of cancer cervix is HPV DNA testing. HPV DNA testing, but it is costly. Otherwise, this is the best screening modality in modern times. For the low resource countries like India, VIA, where you do a mass screening. Otherwise, mostly it is used as a screening test is a pap smear, but confirmatory for pap smear finding is a colposcopy. Fine? Next. Question number 80. Which of the following is a false positive Barr body? I have already explained. What's the answer? Turner syndrome, trisomy 21, Klinefelter, androgen insensitivity. Turner syndrome is 45XO. Klinefelter is 47XXY. Androgen insensitivity is 46XY. Trisomy 21 is at 21 number of chromosome there is 3 set. There is 3 chromosomes, that is trisomy 21. So, where is a false positive? Yes, last 5 year means almost 10 years, 10 papers I am discussing because it is a twice a year exam. So, from 2023 I started and I am going till 2018. I know the questions before that, but it will become too lengthy discussion. So, almost 2023 to 2018, some of the very straightforward single liners I have not added up in this session, otherwise it will become 4-5 hours session. Okay. So, answer to this question is Klinefelter syndrome, where there is a false. Wherever there is a second X present, that is a Barr body or a sex chromatin. Okay. Next question. Question number 81. 55-year-old postmenopausal lady attends OBG clinic and history of chronic pain. X-ray was done and it shows this image. This is 2020 Fmge exam question. What is this image showing? This image where you can see the calcification. And where do you find calcification? This is a calcified fibroid. Okay, calcified fibroid. So please do not mark it as a bladder stone. इतना बड़ा stone नहीं होता, ठीक है? So this is calcified fibroid. Students were confused between a bladder stone and a calcified fibroid. I am damn sure कुछ ना कुछ histories में और भी लिखा था which students are not able to recall. This is a calcified fibroid, no doubt about it. Fine. Question number 82. A female after delivery complains of cramps during the breastfeeding. What is a hormone responsible? Oxytocin. I have already discussed this question. Question number 83. 25-year-old female and her husband presents to the infertility clinic. Semen analysis is normal. Semen analysis is normal. Then HSG shows bilateral distal tubal block or dilatation. So she complains of menorrhagia as well. What is the most likely cause of infertility? Tubal polyp, tubal spasm, genital TB or normal? What do you think fits into this? According to me, the answer was genital tuberculosis. Might be it is written as bilateral distal tubal block or bilateral hydrosalpinx, or it is a presentation of PID. So students are the better judge. Is it a genital TB or it is a PID or it is a distal tubal block or it is a hydrosalpinx? Because if the fimbria are blocked, it will not be able to pick up the ovum and hence infertility. Okay. What will be the best treatment for this case? Best treatment for this case will be IVF, in vitro fertilization. Okay. Best treatment for this case is in vitro fertilization. Fine. Next. Question number 84. A 55-year-old female is found to have cancer cervix stage 3B. What will be the treatment? Concurrent chemoradiation, brachytherapy followed by radiation, radical hysterectomy followed by chemotherapy, hysterectomy followed by chemoradiation. What's your answers? What's your answer? Advanced cancer cervix. What is the treatment? From stage 2B, stage 3, stage 4. The answer is concurrent chemo radiation. Okay. Plus for stage 1A1, 1A2, 1B1, 1B2, stage 2A, 1, you are going to go for surgery. For stages 1B3, 2A2, these are bulky tumors. Bulky tumors. So your management is chemo radiation. So students, Fmge staging, try to revise. Okay. For advanced cancers, the treatment is concurrent chemo radiation. For stage 1, A1, A2, B1, B2 and 2A1, it is surgery. But for 1B3 and 2A2, it is chemo radiation because that is a bulky tumor. Hysterectomy is not preferred in advanced cancers. Okay. Hysterectomy is not preferred in advanced cancers. Fine. Next. Question number 85. History of secondary amenorrhea after DNC, and HSG image shows this. So what do you find in this case? What do you find in this case? It is Dr. Jugal, I can read your answer. What are others? Rudra, KK, Abhishek, Dr. Rupinder, Sarkar, Rahul, Kunal, Vamshi, Krishna, Amulya. So it is Asherman syndrome. Okay. You can see irregular filling defects. Irregular filling defects. Fine. Next. Question number 86. Identify the image. What is this cannula? Is it a Leash-Wilkinson cannula? Is it a Rubin's cannula? Is it a Carman's cannula? What is it? Identify the image. What is this instrument and for what purpose it is used? What's the instrument and for what purpose it is being used? Yes, I can read your chat. This is Leash-Wilkinson's cannula. This is Leash-Wilkinson's cannula. That is used for HSG, hysterosalpingography. In stereosalpingography, we put in a dye, radio opaque dye. Dye enters into the uterus. You can click the X-ray film number 1. Dye entering into the tube, film number 2. Free spill of dye, film number 3. So this is a test to find out uterine pathology. Uterine pathology plus it is a test for tubal patency. You are trying to find out the uterine pathology and it is a test for tubal patency as well. Okay, urographin is the dye we are using. Next, so this is a normal HSG image. Question number 87. Opinion of 2 doctors is needed while you are doing MTP between 20 to 24 weeks. We have already discussed this question. Next, question number 88. Most common site for genital tuberculosis, fallopian tube, uterus, cervix or ovary. 2019 Fmge exam question. Most common site for genital tuberculosis is fallopian tube. 90% of the genital TB occurs in fallopian tube. It leads to blockage of the tube. So most common presentation of genital tuberculosis is infertility and it badly damages the fallopian tube. 40 to 50% site is the uterus and it causes tubercular endometritis and the symptoms can be menstrual disturbances, symptom can be infertility, symptom can be Asherman syndrome because of genital tuberculosis. Vagina is resistant to tubercular infection because it is a multi-layered epithelium. Fine. Next, question number 89. There is a septate uterus responsible for recurrent abortions. What is the best treatment? What is the best treatment for a septate uterus? Best treatment for septate uterus? Answer is always hysteroscopy. Hysteroscopic guided. You can do resection of the septum. Okay, resection of the septum. Next. So this is hysteroscopy and this is what is a septum. This is HSG, this is laparoscopy and this is hysteroscopy. So what is the gold standard treatment? Gold standard treatment for septate uterus is hysteroscopic guided resection of the septum. Next. Question number 90. Drug unsafe in pregnancy in the first trimester is warfarin, propylthiouracil or heparin. What is your answer? What's your answer? Drug that is unsafe in pregnancy. Drug that is unsafe in pregnancy is warfarin because warfarin causes teratogenic effect and these 2 drugs are safe as they do not cross the placenta. Next. Question number 91. Identify the case. Image shown in this question. Is it a placenta previa? Is it a abruptio placentae? Is it a vasa previa? What's your answer? What's your answer? You can see that there is a placenta like this. So placenta in the lower uterine segment is placenta previa. Placenta in the lower uterine segment is placenta previa. Yes, warfarin is safe in the second trimester. Question number 92. Choice of contraception, spacing between the 2 pregnancies for at least 3 years. Answer is copper T. Copper T is a spacing contraceptive to give gap between the 2 pregnancies. Question number 93. Drug of choice for hyperthyroidism in pregnancy in the first trimester. Propylthiouracil, methimazole, carbimazole, or any of the following. What's your answer? What's your answer to this question? Drug of choice for hyperthyroidism in pregnancy in the first trimester. Yes, it is propylthiouracil. Okay, next. Question from Fmge exam 2018. What is the anti-thyroid drug in third trimester of pregnancy? In third trimester of pregnancy. Question from 2018. Answer is carbimazole. Sorry, this is 2019 December Fmge. Another question from 2019 December Fmge was, a patient has thrown 5 convulsions at home. What will be the treatment? So that will be 5 fits at home. Pregnant lady, 34 weeks, what's your treatment? Answer is labetalol plus magnesium sulfate. 1, 2 and third question, 2019 December Fmge. What is anti-epileptic of choice in pregnancy with least teratogenic effect? Answer is levetiracetam. So you can appreciate I am adding up more and more questions which I am remembering. I just forgot to add up in this session because already it is a very lengthy discussion. So many questions I am just telling you. So one question was, what is an anti-epileptic of choice in pregnancy? Answer is levetiracetam. Anti-thyroid drug in third trimester, carbimazole. Then she has thrown 5 fits at home and pregnant lady has come to you, her blood pressure is very high. What is the treatment? This is eclampsia and the treatment is labetalol and magnesium sulfate. So 3 more questions from Fmge exam. Next, question number 94. Drug to be given for MTP for medical abortion. So students, idea of this session is, आप देखो कौन कौन से टॉपिक में से बार बार क्वेश्चंस रिपीट हो रहे हैं, ठीक है. सो MTP, अबॉर्शन, डिसऑर्डर्स ऑफ मेंस्ट्रुएशन, कॉन्ट्रासेप्शन, इनफर्टिलिटी, एक्टोपिक प्रेगनेंसी, ट्विंस, pre-eclampsia, eclampsia. Okay, so all this is very important. Now drug to be given for MTP for medical abortion is mifepristone followed by misoprostol, we have already discussed. Now next is question number 95. अभी ये वाले क्वेश्चंस मैंने नंबरिंग में डाले ही नहीं है, जो ये 3 क्वेश्चंस यहाँ बताए. इससे पहले भी मैंने क्वेश्चंस बताए हैं that I have not added up. So please keep on adding. This is also the important questions. Fine. Now question number 95. Secondary PPH develops after 24 hours. Primary PPH develops within 24 hours. Fine. Next. Question number 96. Type of spermicidal agent used in this contraceptive. 2020 Fmge exam. So 21, 23, 22 I have already discussed. 2018, 19 and 20 I am discussing. Now what is the spermicidal agent in this contraceptive? What is the name of this contraceptive, friends? This is Today. Today is a vaginal sponge. Vaginal sponge. It is a female barrier contraceptive, but it releases a spermicidal agent enoxinol 9. Very correct. Question number 97. Based on this image, what is the likely diagnosis? If you see very clearly, they have marked this image like this. This is urinary bladder and this is vagina, and there is a communication shown. There is a communication shown in this image. So, what is this image? The urinary fistula topic and genital prolapse, students, you usually don't read in your exams, for your exams, but the questions are asked. So, this is vesicovaginal fistula. This is vesicovaginal fistula, and the symptom of vesicovaginal fistula is true incontinence of urine from vagina, continuous dribbling of urine from vagina. So, most common cause for this is obstructed labor. Next, question number 98. Milk ejection reflex is caused by, answer, what's your answer? This is 2011, 2015, 2019, 2018, 2020 Fmge exam. Milk ejection reflex is caused by, answer is oxytocin, we have discussed. It's a very straightforward single liner question. Next, question number 99. So, we are towards the century. Type of congenital heart disease in Down syndrome: endocardial cushion defects, PDA, VSD, ASD. 2018, 2019, 2020 Fmge exam. What's your answer? It is endocardial cushion defects. So, the type of congenital heart disease found in Down syndrome, first answer is endocardial cushion defects. If that is not given, you can mark ASD as your answer. Now, we are towards century. So, this is question number 100. So, almost 100 questions plus जो बीच में डिस्कस किए हैं, तो अराउंड 120 क्वेश्चंस मैं ऑलरेडी डिस्कस कर चुकी हूँ इन दिस सेशन. ओके, सो प्लीज़ डू रिवाइज. I hope you appreciate this session and it is really going to help you out. Formula used to calculate expected date of delivery from last menstrual period is Hadlock formula, Johnson's formula, Neagley's formula or Grenham's classification. What's your answer? Come on, what's your answer for this question? Yes, it is a Neagley's formula to calculate EDD from LMP. You have to add 9 months plus 7 days to LMP, you will get EDD. 4% of the pregnant ladies deliver on the expected date of delivery. What is Hadlock formula? Hadlock formula is to calculate expected weight of the fetus on ultrasound. Johnson's formula is to calculate expected weight of the fetus clinically. Grenham's classification is for placental grading on ultrasound. Okay, Grenham's classification is for placental grading on ultrasound. Question from FMG exam 2018 and 19, that which is the best fetal parameter to find out gestation age in the first trimester? Answer is CRL, crown rump length. Next question 101. All are diabetogenic drugs except 2018 FMG exam question 2023, 2022, 2021, 2020 and 2019 I have already discussed. 2018 I am discussing. Okay, all are diabetogenic except which is not diabetogenic? Cortisol, HPL, insulin, glucagon. What's your answer? Many of the students have marked this answer as wrong. I don't know why. Yes, insulin is not diabetogenic. Insulin is a drug which or a hormone that lowers the blood sugar level. So, insulin, that is why is a drug of choice for diabetes in pregnancy because it does not cross the placenta. It does not cross the placenta. Next, 102. A lady delivered a child and went into shock that is out of proportion of blood loss. Can you explain the cause of this? What's your answer? Lady has delivered a child and she went into shock that is out of proportion of blood loss. What is the explained cause for this? PPH, acute inversion of uterus, amniotic fluid embolism, or rupture uterus? What's your answer? HPL is human placental lactogen. Human placental lactogen. HPL is secreted by placenta and it transfers glucose from mother to fetus. It transfers glucose from mother to fetus. Fine? Next. So what's your answer? Yes, this is acute inversion of uterus. So out of proportion of blood loss because this is neurogenic shock. So initially the shock that develops is neurogenic shock, later on it is hemorrhagic shock. And what is the cause of death in acute inversion of uterus? The answer is, it is hemorrhagic shock. The cause of death in acute inversion of uterus is hemorrhagic shock. Clear? Question number 103. All of the following are markers for triple test except. This has been a very favorite question of Fmge exam. All of the following are the markers for triple test except HCG, alpha-fetoprotein, estriol, estradiol. So wrong answer is estradiol is not a marker for triple test. Okay. Triple test includes alpha-fetoproteins, beta HCG and unconjugated estriol. Okay. So for trisomy 21 and trisomy 18, alpha-fetoprotein decreases, HCG rises, estriol decreases. All decreases in trisomy 18. Trisomy 21 is Downs. Trisomy 18 is Edwards syndrome. And trisomy 13 is Patau syndrome. Another question from Fmge exam. What is trisomy 18? Answer is Edwards syndrome. Trisomy 18 is Edwards syndrome. So that is one more question, and this is question number 104. Another MCQ in Fmge exam was an image based question of nuchal translucency. Nuchal translucency is a marker for aneuploidy, that is Downs on ultrasound. Okay. So question number 104. Yes, this is useful for NEET also. Dr. Gaurav, I am going to take up a NEET PG session separately. INI CET 5 years session and rapid recap for INI CET exam also I have already taken. You can go through the YouTube link and go through that video. Plus, I have already discussed a UPSC session also. You can go through that. Okay. Students, this answer which is out of proportion of blood loss, this does not mean hypovolemic shock. This means they are asking about neurogenic shock. Okay friends, this they are asking about neurogenic shock. So this statement is specially for acute inversion of uterus. Thank you so much students, you are appreciating this session not only for FMG but for NEET PG preparation as well. But I am going to bring up a NEET PG session in just few days. The previous 5 years questions. Okay. Now next, female organ equivalent to prostate gland, Cooper's gland, paraurethral glands of skin, glands of Cloquet or Bartholin gland. What's your answer? What's your answer? Nowadays the pattern is going to be more and more clinical. That is why I have discussed the clinical questions first. Prostate gland in the males is equivalent to Skene's gland in the female. Okay, and Bartholin gland in the female is homologous to Cooper's glands in the males. Okay, 2 questions. Fine. Next, question number 105. Hormone responsible for transfer of glucose from mother to fetus. I have already discussed this. So I would like to visualize your chat. What's your answer? What's your answer? Hormone that transfers glucose from mother to fetus is HPL, human placental lactogen. What is the hormone that is responsible for fetal growth and development? Fetal growth and development. The one and only one hormone, insulin. Whose insulin? Fetal insulin. Okay. Fetal insulin is secreted as early as 12 weeks of intrauterine life. Fine. Question number 106. Muscles attached to perineal body are all except. Muscles attached to perineal body are all except bulbospongiosus, pubococcygeus, ileococcygeus, external anal sphincter ani muscle. So the correct answer is ileococcygeus is not attached. It is the pubococcygeus muscle which is attached. So rest are correct. Ileococcygeus is wrong. Next, 107. Basal metabolic rate in pregnancy is increased by 30%. Next, 108. If the division of fertilized ovum takes place within 72 hours, name the type of monozygotic twins. What's your answer? So many exams this question has been asked. If the division of fertilized ovum takes place within 72 hours, name the type of monozygotic twins. Is it diamniotic, dichorionic, monoamniotic, monochorionic, diamniotic, monochorionic or Siamese twins? What's your answer? Dr. Amulya has written A, Dr. S, Dr. KK, Dr. Pal, Dr. Abhishek has written A, Dr. Kahe, Dr. Rupinder. So the correct answer is diamniotic, dichorionic. C. If division is occurring within 72 hours, it is diamniotic, dichorionic. If division is occurring between 4th and 8th day, it is diamniotic, monochorionic. If division is occurring after 8th day, it is monoamniotic, monochorionic. If it is occurring after 13th day, it is Siamese twins. Overall, which is the most common type of twins is dizygotic twins, which is more common than monozygotic. Okay, and dizygotic twins are always diamniotic, dichorionic. Fine. Next, 109. McDonald stitch is applied in septate uterus, incompetent cervical os, placenta previa, or bad obstetric history. What's your answer? Siamese twins is conjoined twins. Siamese twins are conjoined. They are either joined from head to head, thorax to thorax, abdomen to abdomen. Okay. Now, McDonald stitch is applied for. It is cervical incompetence. I have already explained. McDonald stitch, when cervix is open, it will lead to second trimester abortions. So, a stitch is applied at the level of internal os with non-absorbable suture. And timing of this stitch is around 14 weeks or 2 weeks earlier than previous pregnancy loss. And you can remove this stitch any time after 37 completed weeks, or if leaking per vaginum or bleeding per vaginum starts, or she goes into preterm labor pains, then you might have to remove this stitch. Fine. Next, question 110. How frequently fetal heart rate is monitored in partogram in first trimester of pregnancy? How frequently fetal heart rate is monitored in first trimester of pregnancy? Sorry, in first stage of labor. I beg your pardon. In partogram in first stage of labor. What's your answer? 30 minutes, 45 minutes, 60 minutes, or 90 minutes? Write down your answer. Write down your answer in the chat box. How frequently fetal heart rate is monitored in partogram in first stage of labor? Answer is 30 minutes. In partogram, fetal heart rate is monitored every 30 minutes in first stage of labor and every 15 minutes in second stage of labor. Okay. Pulse rate is monitored every 30 minutes. Blood pressure is monitored every 2 hours. Temperature is monitored 4 hours. Per vaginum examination 4 hours. Partogram monitoring every 30 minutes. Then uterine contractions every 30 minutes. This table is important for you. And partogram plotting is started from 4 centimeters of cervical dilatation according to WHO modified partogram. WHO modified partogram. Clear, students? Next, question number 111. True labor pains is represented by dull in nature, pain and discomfort, show, or relieved by enema and sedation. What's your correct answer? What's your answer? Dull aching in nature, that is a feature of false labor pains. True labor pains are always painful. True labor pains are always painful. And there are uterine contractions. This is false labor pains. Show is always a feature of true labor pains. They are not relieved by sedation and enema. So, the correct answer is presence of show. Question number 112. Head compression causes late deceleration, early deceleration, variable. So, answer is early deceleration. So, normally there is uterine contractions and fetal heart rate is normal. This is CTG, cardiotocographic monitoring. So this is normal fetal heart rate and this is uterine contractions. So head compression causes early deceleration, like this is uterine contraction and there is a dip of fetal heart rate with the contraction. So this is early deceleration. Variable deceleration is seen in, this is chronic placental insufficiency, there is late deceleration like uterine contraction and fetal heart rate dip occurs after the contraction is over. Variable deceleration is seen in cord compression. So, head compression causes early deceleration, cord compression causes variable deceleration and chronic placental insufficiency which occurs in PIH or IUGR, it causes late deceleration. Variable deceleration is that it is not related with contractions. Okay. So, head compression early deceleration, cord compression variable deceleration and chronic placental insufficiency late deceleration. Next, 113. Longest fetal skull diameter is mento-vertical, which is 14 centimeter, presentation is broad, management is cesarean section. Okay. So, fetal skull, the largest diameter is mento-vertical, which is 14 centimeter and the presentation is broad and management is cesarean section. Next, 114. Bishop score is used to calculate see Dr. Amulya, I just know about my subject, I have taken the discussion because OBS Gynae is very important and rest the availability of the faculties because they are also busy in taking their classes in different batches or in the upcoming apps. Okay. So, this is for the team to decide. Okay. Some of the discussions and questions are already there on the YouTube channel, you can watch that and maybe there will be more sessions organized by the academy. Okay. So, as far as my subject is concerned, I am the first one to discuss this because I feel this is very important and academy also felt this is very important. Rest depends upon the availability of the faculties. Some of the discussions or the test and discussion session is already been there as a live session in the subsequent days and some has already been posted in the YouTube channel of Ellen. You can go through, you can subscribe the channel. Bishop score is used to evaluate fetal well-being, uterine contraction, cervical status. It is for cervical status. When we do per vaginum examination, we check for cervical dilatation, cervical effacement. Nowadays, we call it as cervical length. Then, consistency of cervix, position of cervix and station of fetal presenting part. These are the 5 parameters we take into consideration for Bishop score, which is a scoring for cervical status, so as to decide you allow normal delivery or induction or augmentation of labor or do a cesarean section in high risk pregnancies. Okay. Now, question number 115. Which of the following is not recommended for heart disease in pregnancy? Cut short the second stage of labor, IV methergine to be given, oxygen by mask, prophylactic antibiotics. What's your answer to this question? Question number 115. Now, we are almost at finishing our session for today, but many of the 20-30 questions during the sessions I have added up with the questions. बीच बीच में मैंने और भी आए हुए questions इसमें add कर दिए, ठीक है, बट हो सकता है कुछ थोड़े बहुत क्वेश्चंस रह भी गए हों, बिकॉज जितने मैं कलेक्ट कर सकती थी उतने मैंने कलेक्ट करे हैं, जितने मेरे अपने लैपटॉप में थे उतने मैंने सारे क्वेश्चंस कंपाइल करके ये सेशंस प्लान किया है, सो एज टू हेल्प यू आउट अकॉर्डिंगली यू कैन प्रिपेयर योर स्टडीज फॉर द एग्जाम. सो IV methergine is not been given in cases of heart disease after the delivery of the placenta, because ये क्या करेगा, it will cause strong contraction of uterus, pushing all the blood to the systemic circulation and heart failure can get precipitated. So this is not acceptable. Fine. Now question number 116. A lady comes at 16 weeks of pregnancy presented with bleeding per vaginum. On examination, cervix is open. Products of conception are felt. There is bleeding. Cervix open. Can you tell me the diagnosis and the management? Question on the management was asked in 2013. And what is this question? What is the answer to this question? She is 16 weeks pregnancy, bleeding per vaginum, cervix is open, no products have expelled. What's your answer? Is it threatened abortion, inevitable, incomplete or complete? Yes, this is inevitable abortion, because if products have come out then it will become incomplete. So cervix is closed, that is threatened abortion. Cervix is open, that is inevitable. Products have expelled out, that is incomplete, and cervix closed, that is complete. So this is inevitable abortion. That is the correct answer, and management is D and E, using ovum forceps. D and E, using ovum forceps. Fine. Next, question number 117. Expectant management for placenta previa. Expectant management means conservative management. What is the name of conservative management for placenta previa? Where you are hospitalizing the patient, you are doing a maternal fetal monitoring, and you are not doing termination. What is that management called as for placenta previa? What's your answer? Is it McAfee-Johnson's, is it Creedy's method, is it Lilly's method, or it is Brand Andrews method? What's your answer? Yes, it is McAfee-Johnson's management, which is a conservative management for placenta previa. This is done for placenta previa. Period of gestation is less than 37 weeks, but maternal and fetal condition is stable and there is no active bleeding at present. No active bleeding at present. So you admit the patient, hospitalize, do the monitoring, put her on tocolytic agents, give steroids for lung maturity, and take the consent and prepare the blood ready. If there is any more bleeding, you can transfuse the blood. Okay, so that is McAfee-Johnson's management. Next, question number 118. All of the following are the causes of coagulopathy except accidental hemorrhage, placenta previa, eclampsia, amniotic fluid embolism. So what's your answer? All of the following are the causes of coagulopathy. Coagulopathy means DIC, disseminated intravascular coagulation. So what's your answer? Accidental hemorrhage, placenta previa, eclampsia, or amniotic fluid embolism? What's your answer? ठीक है, so what's your answer, students? Write down in the chat box. So placenta previa is never the cause of coagulopathy. Causes of coagulopathy are abruptio placentae, dead fetus, septic abortion, pre-eclampsia or eclampsia, and amniotic fluid embolism. So these are the causes of coagulopathy where there is a formation of clot. Okay, so abruptio is the most common cause for coagulopathy or abruptio is the most common cause for coagulopathy or DIC. Next, question number 119. A pregnant lady comes with a red degeneration of fibroid. Management is. Red degeneration of fibroid occurs in the second half of pregnancy. Are you going to do hysterectomy, conservative, termination of pregnancy or myomectomy? What's your answer? What's your answer? This is a very, very important question and students tend to mark it wrong. What's your answer? So what's your answer, students? नंबर नहीं दिख रहा मुझे. नंबर ऑफ नंबर नहीं आ रहा है इसमें, उसमें आ रहा था. So pregnant lady comes with a red degeneration of fibroid. Management is. Answer, the management is conservative management. Whenever there is a fibroid in pregnancy, that's never an indication to perform any type of surgery. So always you go for a conservative management. That means you admit, put the patient on bed rest, give analgesics, IV fluids, that's it. So this is what is a conservative management. So red degeneration occurs, a fibroid occurring in pregnancy. Okay. Next, question number 120. So deep transverse arrest is seen in which type of pelvis? Gynecoid, platypuloid, android or anthropoid? If had it been a PGI exam, then it's two answers, but if it was an MCI question, so one answer, that is android pelvis. Okay. Next, question number 121. Name the type of presentation when the fetal head is partially flexed. So what's your answer? Face, vertex, brow or none? What's your answer? What's your answer? Yes, this is a brow presentation. When neck is completely flexed, it is vertex. Neck of the fetus is completely flexed, it is vertex presentation. When it is partially extended, it is brow presentation. When it is completely extended, it is face. Like completely flexed, it is vertex, partially extended, it is brow, completely extended, it is face. Okay. What is the denominator in face? Mentum. Diameter is 9.5, so normal delivery can take place. Brow, the diameter is 14 centimeters, delivery cannot occur, so it is cesarean section. Vertex, the occiput is the denominator and diameter is 9.5, so delivery can occur. Fine. Next, 122. In WHO modified partogram, labor progress is plotted from how many centimeters of cervical dilatation? 4, 5, 3 or 7. So the correct answer is 4. Question number 123. Causes of polyhydramnios are all except diabetes, esophageal atresia, renal agenesis or anencephaly. What's your answer? What's your answer? So what's your answer for this? Causes of polyhydramnios are all except diabetes, esophageal atresia, renal agenesis or anencephaly. Baby keeps on drinking the liquor and keeps on producing the liquor. Okay, when there is defect in drinking or there is more production, polyhydramnios occurs. So anencephaly, open neural tube defects, esophageal atresia, diabetes, tracheoesophageal fistula, all these are the causes for polyhydramnios. There is more production or there is defect in drinking. Renal agenesis causes oligohydramnios. Renal agenesis causes oligohydramnios. Next, question number 124. Most common bone to be fractured in difficult deliveries. Answer is clavicle. Most common bone to be fractured in difficult deliveries is clavicle. Next, question number 125. First sign of puberty in girls. First visible sign of puberty in girls is thelarchy. Hormone responsible for thelarchy. Thelarchy means breast development. Hormone responsible for thelarchy is estrogen. First sign of puberty in girls. If this is a question, then your answer is growth spurt. But since growth spurt was not given in the option, so first visible sign of puberty in girls is thelarchy. And hormone responsible for puberty is androgens. Hormone responsible for hair development, axillary pubic hair is androgens. Fine. Next. Question number 126. Most common cause of hirsutism in young girl. What's your answer? PCOD, congenital adrenal hyperplasia, adrenal tumor or ovarian tumor. Most common cause of hirsutism in young girl is, what's your answer? Most common cause of hirsutism in young girl is PCOD. Fine. This is very straightforward question. And what is the first step in management of PCOD with hirsutism? Answer is lifestyle modification. And next, second line is the drugs. And OCPs is the drug to be given for hirsutism. Fine. Next. Question number 127. Treatment of choice for young female with primary dysmenorrhea is dilatation of the cervix. Will you do that? Symptomatic, hysterectomy or presacral neurectomy. What's your answer? So the answer is symptomatic treatment. We give tablet, Meftal-Spas, that is mefenamic acid and dicyclomine combination. Fine. Next, question number 128. Pearl index is used for family planning method, contraceptive failure, IUCD insertion or demography. What's your answer? I can read your answers. Dr. KK, Dr. Raja, Dr. Medico, Dr. Rupinder, Dr. Vijay, Dr. Daksh, Dr. Rajat. All of you are writing very correct answers. Dr. Sandeep, yes. Dr. Abhishek Sankla, very correct. Now tell me the next answer. Pearl index is used for contraceptive failure or for accidental pregnancy. Pearl index is used for contraceptive failure or accidental pregnancy. Next, question number 129. 32-year-old female P2L2 comes with 4 days after unprotected coitus asking for contraceptive advice. So they have come after 72 hours. What is your contraceptive advice? She is already a married patient, multiparous. What's your answer? Yes, Dr. Abhishek, Dr. Debatru, Kundu, Dr. Sandeep, Dr. Tanya, Dr. Gautam, Dr. Saif, Dr. Taimar. It is correct answer, copper T. Question number 130. Timing of IUCD insertion according to latest guidelines after delivery is within 10 minutes of placental delivery. Within 10 minutes of placental delivery. Next, question number 131. Contraceptive with maximum failure rates. Is it spermicidal agent? Is it condoms? Is it OCPs? Is it IUCD? What's your answer? What's your answer? Contraceptive with maximum failure rates. Yes, it is a spermicidal agent. Spermicidal agent used alone, the failure rate is 30 per 100 women year. Condoms, the failure rate is 2 to 10 per 100 women year. OCP, the failure rate is 0.1, the least failure rate and best contraceptive. Failure rate of IUCD copper T 380A 0.6 per 100 women year. Copper T 380A. So, spermicidal agent has got a maximum failure rates. Next, question number 132. WHO cutoff value for sperm count is 15 million per ml. 15 million per ml. Question number 133. Hormone markedly elevated in a menopausal female is FSH, GnRH, estrogen or progesterone. They have also asked this question in 2020 exam. Hormonal profile in a menopausal lady. What's your answer? What's your answer? Question number 133. What's your answer? Hormone elevated in a menopausal lady. Yes, I can see Dr. Shubham, Dr. Rupinder, Dr. Daksh, Dr. Tanya, Dr. Medicos, Dr. Gaurav, Dr. Vijay Prajapati, Dr. Kundu, Dr. KK, Dr. Islam, Mofiz Islam. So this is FSH and here also it is FSH LH elevated. Fine. Next, question number 134. Earliest to rupture ectopic pregnancy. What's your answer? Earliest to rupture ectopic is, yes, Dr. Tanya, I can read your answer. Dr. Rupinder, Dr. Gaurav. What's the answer of my next question? I am towards finishing the session. Only 10-12 questions more are left. Rest I have already covered up. Plus 20-30 extra questions also I have discussed. So what's your answer? Earliest to rupture is ischemic rupture, less than 6 weeks. Late to rupture is interstitial, around 3rd to 4th month of pregnancy. Ampullary rupture is 8 to 10 weeks. Most dangerous type of ectopic pregnancy is interstitial. Most dangerous type of ectopic pregnancy is interstitial rupture, is very, very dangerous. Next, question number 135. All are criteria for giving methotrexate for unruptured ectopic pregnancy except beta HCG less than 10,000, gestation sac less than 3.5 centimeters, cardiac activity present, and free fluid in pouch of Douglas, which is not a criteria for giving methotrexate as a medical treatment for unruptured ectopic. What's your answer, friends? It is cardiac activity present. Cardiac activity should always be absent. That is the most important criteria. Cardiac activity should be absent is the most important criteria. Next, question number 136. Intrauterine pressure during laparoscopy is 5 to 10 millimeters of mercury, 10 to 15, 15 to 20 or 20 to 30. What's your correct answer? Intrauterine pressure during laparoscopy is 10 to 15 millimeters of mercury. Exact answer is this, which is a gas used to create a pneumoperitoneum. Gas used to create pneumoperitoneum is carbon dioxide. 1 to 2 liters gas is been filled to create a pneumoperitoneum. Okay. Next, question number 137. Which of the vaccine is a quadrivalent vaccine against HPV? Which is a quadrivalent vaccine? Gardasil, Cervarix, nonavalent vaccine. What's your answer? What's your answer for question number 137? Which of the following is a quadrivalent vaccine against HPV? Yes, answer is Gardasil, that is HPV 6, 11, 16, 18. Cervarix is HPV 16 and 18. Nonavalent is HPV 6, 11, 16, 18, 31, 33, 45, 52 and 58. So this is the nonavalent vaccine, 9 variants. Okay. Next, question number 138. So all are risk factors for endometrial cancer except obesity, diabetes, hypertension, feminizing ovarian tumors, late menarche, late menopause, early menarche, late menopause, late menarche, early menopause. Which is protective? Which is protective? So I can read your chat. All are the risk factors for endometrial cancer except Dr. Daksh, Dr. Raja, Dr. Amit. I can read your answers. Correct. Late menarche and early menopause is going to be protective. It's going to be protective. Rest are the risk factors for endometrial cancer. Fine. Next, question number 139. Best treatment for stage 1 grade 1 endometrial cancer. Hysterectomy, chemotherapy, radiotherapy or radio chemo combined. What's your answer? Stage 1 grade 1 cancer is hysterectomy. Stage 1 grade 1 cancer is hysterectomy. Next, question number 140. Most common menopausal symptom is always vasomotor symptoms like hot flashes. Okay, why this happens is because of estrogen withdrawal. Because of estrogen withdrawal. Okay, most common menopausal symptom is vasomotor symptoms, that is hot flushes due to estrogen withdrawal. Okay, due to estrogen withdrawal. Next, question number 141. The diagnostic criteria for bacterial vaginosis include all except presence of clue cells, homogeneous vaginal discharge, positive whiff test, or vaginal pH less than 4.5. This I am going to wait for your answer. You have to tell me your answers. I am almost towards concluding my session for today. What's your answer to the next question? Question number 141. Which of the following is not a criteria for bacterial vaginosis? The correct answer is vaginal pH. Vaginal pH should be more than 4.5. Clue cells is correct, homogeneous discharge is correct, whiff test is correct. This is all EMSAL's criteria. So lactobacillus should be absent. When lactobacillus is less, the pH will become more alkaline. Okay, next. Question number 142. Asymptomatic gonococcal carrier organism lies in, answer, endocervix. Organism lies in endocervix. Next. 143. 25-year-old nulliparous third degree cervical uterine descent with no cystocele rectocele. What is the treatment? Next question. What is the treatment? Question number 143. Dr. Rudra, why you are marking so many times the same answer? You are correct, you are excellent, you have been attentive throughout the session. But why you are marking so many answers? Same answers many times. You are correct, I agree. So what's your answer to this next question? Genital prolapse, this is very, very important. What will you mark for a nulliparous prolapse? Answer is abdominal sling operations. Abdominal sling operations. Next, 144. Most common cause for vesicovaginal fistula in India. What's your answer? Quick. I'm almost concluding my session for today. It's been a wonderful crowd. I can see so many students attending this session. What's your answer for the next question? 144. Most common cause of vesicovaginal fistula in India. Dr. Rudra, it's okay, yaar, come on. Don't be so silly. You're so attentive, you're so lovely. But sorry, I can't see your face. That's the limitation. So yes, all of you are correct. It is obstructed labor. Now question number 145. This type of IUCD is freely available in India. What's this IUCD, friends? Next, come on. What's this IUCD? Thank you, Dr. Devendra, for appreciating this session. Thank you so much, ma'am. This was an awesome session. Thank you so much, students. What is the answer to this question? Come on. Yes, Dr. Saif, Dr. Gaurav, Dr. KK, Dr. Yasra, Dr. Daksh, Dr. Rupinder, Dr. Vamshi, Dr. Tanya, Dr. Tahir, Dr. Vijay Prajapati, Shasta Farooq, Shubham, Taimar, Dr. Sanjay, Dr. Abhishek Sankla, Dr. Islam, Dr. Harsh Rawat, Dr. Sandeep, Dr. Medico, Dr. Gaurav, Dr. Amit, Dr. Karanbir, Dr. KK, Dr. Amulya, all correct. This is copper T 380A. So 145 plus around 35 questions more, around 180 MCQs I have discussed, and like maybe 10 or 20 questions. I am not able to get it, or it was a long session. It was more of a single liner type of questions, which might be I have just left it. Yes, thank you so much, students. It was a great session, wonderful students, wonderful batch of students. Okay, so go through this. Maybe I'm going to plan some more session, maybe some 100 key points or MCQs, or like single liners I'm going to bring up, that is just before exam. Yes, Dr. Devendra, मुझे भी बहुत मज़ा आ गया. Love you all, students. Wonderful batch. So here I take up your leave and thank you so much and all the best for your upcoming exam. Do your OBS Gynae subject so well, prepare the other subjects as well, stay connected with us and thank you, love you all. Bye-bye. I love your replies, amazing students, thank you so much, bye-bye.